some of the brightest minds shaping the future of health in our country. I am truly honored to be part of this important gathering of researchers and public health professionals. I hope you had a refreshing lunch break and are re energized for the session ahead this afternoon. We now will proceed to parallel session 8, which focuses on health inequalities, social determinants of health, health education and promotion, as well as implementation research, areas that remain central to improving health outcomes and equity in our communities. A very warm welcome to all our presenters, participants, and guests. We are delighted to have you here with us today. We are pleased to have two distinguished experts chairing this session. Let me begin by introducing our chairs. Dr. Radhika Thapalia, a public health professional serving as director at National Health Education Information and Communication Centers under the Department of Health Service in Nepal. She is actively involved in designing and implementing health communication strategies at national level. Radhika ma'am, I invite you to kindly come forward and take your seat on the dais. Next, we are honored to have Professor Madhusudan Subedi. Professor Subedi is a professor at Patan Academy of Health Science, Nepal, a distinguished researcher, social scientist, and consultant. He has made significant contribution to academic research and public health through his work on social sciences and consultancy. Sir, may I request you to kindly take your seat next to Ms. Radhika Thapalia on the dais. Thank you both for being here today. With that, I now request our chairs to take the session forward. Over to you, chairs.
Thank you. Thank you very much. Without any delay, we will start our program. Uh, shall I kindly request Professor Dr. Saraj Raj Onta to present his issues, health in Nepal from perspective of equity. Professor Onta is a former member secretary of Nepal Health Research Council, renowned public health experts, and professor of community medicine and public health, Institute of Medicine, Tribhuvan University. Professor Onta, floor is yours, please.
Next slide. Okay.
Kindly finish, all the presenter finish your presentation on time, so that if we will get time, we will discuss question and answer at the end of session.
Okay.
Thank you.
So let me just set the time. No, please remind me, okay, because I can't set here time. Thank you very much. Let me start with some few points of disclaimer. My first point is that when I was asked to provide some delivery presentation, I was given a framework and the guidelines how it should be prepared. But unfortunately, I have not done that. Therefore, this is very different kind of presentation. So please bear with me for that. And secondly, in my presentation, I have used only secondary data. I have not used primary data, and I have reanalyzed this data, available data, to fit to my presentation. And third point of my disclaimer is that only a small part of my article is being presented here. This is just a small part of my presentation. Otherwise, I'm preparing a large article on health in Nepal from the perspective of equity. Please. So, when you talk about equity in health, so when you talk about equity in health, there are commitments and there are a lot of dilemmas. And I would just like to see that Nepal has committed for equity in health, because it's not possible to to explain everything. We have committed as health right in our constitution and in our Health Service Act and in policy and also in the programs. But despite that, country is facing a lot of dilemmas. The one of the dilemmas I'm going to highlight is how to measure it and what has been the output of the our programs. When we talk about how to assess the equity, it's a big question, and there has been a lot of discussion about it. How to assess the method? There are a lot of methodological problems, but what we think is when we assess in the form of inputs, which includes policy and its implementation, which has been discussed in last sessions also, I mean, yesterday's. And we also measure the equity in terms of output of our input, which are availability of services and access to the services, which is very important. And also we measure the outcome of our inputs. The outcome is there are a lot of outcomes we can assess, but at this point of time, I'm taking at the health status of the people and financial burden. These two are very, very important outcomes of our inputs and outputs. Therefore, based on reality and based on rationality and logically, I have been using as example health status of people and financial burden. When you talk about the health status of people, we discussed a lot in yesterday's sessions when we began the whole this summit, that we have done good improvement. Yes, we have done a lot of improvements in health status and indicators, because if you take just child mortality, it's not possible to include all the indicators. But if you just example of child mortality, of course, over the last 3 decades, we can see the improvement and the reduction of child mortality in very significantly. I don't want to compare it with other countries, because Nepal is not the only country which has reduced the child mortality. There are many other countries, and therefore I'm not going to compare with other, but I'm just saying that we can see how this has been decreased. But from the point of equity and justice in health, this progress, just reflected in national average, will hide the disparity in health. They will push the whole the spirit and the concept of equity in the shadow. Is extremely important, that if we have reduced the child mortality, whether this is under 5 mortality or neonatal mortality or infant mortality, we are always talking about the gross national average. There are so much difference. There are geographical difference, because the rates are different in high mountain and different in hills and different in Tarai, and there are difference in different provinces. If you compare this from far west to Bagmati provinces, we can see a lot of differences in those indicators, and there are urban-rural differences. I'll not talk in detail about that, but I'll also try to somehow reflect some concept of economic status. I mean, how the economic status of people will make the difference in the indicator. This is how there are a lot of differences, and we'll not be discussing every difference, but I'll try to, see not geography, not residency, but I want to focus on how economic status has made significant difference in the health. And I think I'll take only uh, some examples. As I said that these are only taken from, I mean, these sources, this is not my primary data. I believe in NDHS data. I trust it, and I have used the NDHS data and reanalyzed somehow. See, if you look at the just infant mortality rate, I mean, I'm talking about in 2022, the latest NDHS report. The infant mortality rate was 28 per thousand live births. But see, among the poorest people, this rate was 45 per thousand live births. Sorry. Is it? And, sir, thank you. And among the richest families, it's not it either. Among the richest families, you know, the infant mortality rate is, you know, how much is infant mortality among the richest? Is 15 per thousand live births. The poorest families have 45 per thousand live births, and richest families have 15 per thousand live births, with the average of 28, with the national average of 28. We always count 28, 28, and 28. And you know, if we calculate the difference between the highest and lowest, that is 107% difference compared to the national average. I think this is only in infant mortality rate. If you look at the neonatal mortality rate, this difference is 85% among the richest and poorest. And if we compare the mortality rate of under 5 mortality under 5 children, the difference between the richest and the poorest families is 112%. It means the poorest have more than double under 5 mortality compared to the richest families of the country. I think this should be extremely important, and the national average will hide this kind of disparity in health. Therefore, the socioeconomic status, I have used only one indicator, socioeconomic status. We can, if we compare between rural and urban, we find the same difference, maybe slightly different. And if we compare, in fact, the mortality rates between different provinces, we can see the similar differences. But economic status is more important. Therefore, I have used this indicator. So further, I'll just assess, you know, the child mortality. This is not only in 2022. This is not just one-time event. This differences is seen not only in one NDHS report. If you look at the, you know, differences in the last 4 surveys, because the economic status is included only from 2006. In NDHS 2001 and 2019, and before that, the economic status or the wealth quintile was not included in survey. It was started include only from 2006. Therefore, I have used from 2006 in among the infant mortality rate. See, in 2006, the difference between the highest and lowest infant mortality rate was 64% among the richest and the poorest family. This has been increased in 2022 to 107%. It is, you know, we have reduced the national average from 48 to 28. We reduced in 3 decades significantly, but see the difference between the richest and poorest families. I think this is amazing. I don't think we should forget this issue. Therefore, this indicators I said, of course, the whole issue of equity and justice in health. Please note me, okay? And now people experience the next indicator is the economic burden or financial burden to the family because of the expenditure in health. I just want to some example. Like people experience very high cost of health services, and there are multiple factors why health services are so high in this country. I think we are not going to analyze that, but impact of the burden of the cost of the services are so much different between the rich and poor people. I just want to give one example and I will finish it. So, among the indicators, financial indicators, I'm not a health economist, but I see the economics from public health point of view. One of the indicators is, the study said, we discussed about out-of-pocket expenditure, but I'm talking about out-of-pocket expenditure. I do not take it as a very sensitive indicator to assess the inequity. I take catastrophic expenditure in health. The catastrophic expenditure in health means this is serious and sensitive indicator. It means how people have to, pay for the services. Because they have to pay for the services, the cost of the health services are more than what they earn. That is what we call catastrophic expenditure. To pay for health services, people have to sell their property, or people have to borrow loan, or they have to compromise with the different options. They have to pay for the services. And in Nepal,
Sir,
11 point.
Sir, please.
Okay, 11%.
Conclude, please.
Okay, yeah. I'm just concluding. 11% of service user or families experience catastrophic expenditure on health. And that among the 11%, see, the poorest families experience 16.6% of the poorest family. And richest family, among the richest family, 7.5% experience catastrophic expenditure. Therefore, there is an extreme burden of health expenditure in poorest family. So this is only thing is there are when we talk about the way out, what we should do that. No, there are multiple ways I can say, but one thing I just want to assess. Finally, what we should understand that the market economy theories are applied in health. The market has converted health services into the commodity selling in market, and market has converted how we service users into the customers or consumers. Therefore, we have to really now generate health economic theories to replace the market economic theories in health. This is extremely important because just recently we had this session on industry and academia. I was very, very unhappy to see that it was not included because sometimes we will be discussing what does health economics theory means. And we should really, really ignore the market economic theory. Market doesn't understand what is equity. Market doesn't understand what is justice. So,
thank you, sir.
I think,
thank you very much. Thank you.
We have to continue to discuss this very serious issues. Thank you very much. Thank you very much.
Thank you, sir. We would like to invite Dr. Bipin Adhikari, who is a senior social scientist at the Mydol Oxford Tropical Medicine Research Unit, Faculty of Tropical Medicine, Mydol University, Thailand. He is also affiliated with the Center for Tropical Medicine and Global Health, Nuffield Department of Medicine, University of Oxford. Over to you, Dr. Bipin.
Right. Start. Hello everybody. Namaste सबैलाई. यो आज सेसनको थिमसँग मिल्दोजुल्दो गरी सरोज सरको टकसित पनि थोरै इक्विटीसित थोरै मिलोस् भन्ने हिसाबले प्लस मेरो डिसिप्लिनरी एक्सपर्टिज कम्युनिटी इन्गेजमेन्ट भएको कारणले आई विल ट्राई टु आजको सेसनको अब्जेक्टिभ चाहिँ थोरै कम्युनिटी इन्गेजमेन्टको बारेमा मैले कलेक्ट गरेका अनुभवहरू सेयर गर्न चाहन्छु. रोल अफ कम्युनिटी इन्गेजमेन्ट इन ग्लोबल हेल्थ रिसर्च, अनि त्यसपछि वाइ कम्युनिटी इन्गेजमेन्ट इज क्रिटिकल इन ग्लोबल हेल्थ रिसर्च एन्ड हाउ क्यान वी इम्प्रुभ द करेन्ट रिसर्च प्र्याक्टिस. अब त्यही अनुसार we did a targeted malaria elimination community-based clinical trial in Southeast Asia that included Vietnam, Laos, Cambodia, Myanmar, and community engagement was essential, essentially to achieve high coverage, high participation. Basically, from the researcher's perspective, community engagement is to achieve high participation, but from the ethical perspective, it is to safeguard the participants' rights, for example. This was a major project where mass drug administration was employed. I will be rushing through the slide because I want to conclude it within 10 minutes. So we don't know what the definition of community engagement is. If somebody says community engagement means this, I will first be suspicious. It can mean anything. That's the heterogeneity we have with what means community engagement. Nonetheless, we did try to do as much as possible to include all the aspects of community engagement. For example, formative research, field observation, designing community engagement itself together with the community members, and then doing the intervention, that is mass drug administration, and then finally assessing the acceptability of mass drug administration. So basically, for scientists, effectiveness of mass drug administration is achieved when more than 80% of the population participate. If less than 80%, perhaps, the mass drug administration would fail. So that's the sort of critical value for them. But what about for social scientists and others, and for the community members? That's the sort of area I want to take you through. That was the research site in remote Laos, very remote. These are ethnic minorities. Just trying to show you some of the activities there. This is a sort of timeline of the work that I'm trying to present here. It's a massive, packed up project. As I said before, community engagement is a very heterogeneous concept. Nobody knows what it includes and what it doesn't. Nonetheless, it doesn't leave us with some kind of fluid sort of activities. We need to be conscious of what works, what doesn't work. So basically, what we learned from the systematic literature review was collaborate with the authorities at various levels and have local people within the project so that they can help us implement the project. So the first encounter was we were targeting healthy people, so asymptomatic malaria, asymptomatic people, or the normal people, for example, apparently normal people, healthy people. They wouldn't want to take the mass drug administration for apparent no illness. So asymptomatic malaria itself was a major hurdle. Nobody would want to know, nobody would want to buy our concept. So treatment-seeking behavior was again another major hurdle. We wouldn't know how people think about the illness, how they conceive it, and how mass drug administration would play out. So this went on for a while until we realized we could try, translate these concepts into local language. This is in local Lao language. We tried to build up a story on the right-hand side, which may have worked, may not have worked. We can only say it may have contributed. We cannot attribute. But luckily, the coverage was 80%. But we are still unsure whether we can attribute to community engagement, or we could say community engagement may have contributed. What comes to my mind when looking at various themes, working through various data, is trust. Trust becomes the central crux of community engagement. How do you build trust? Where do you start? Those are the sort of questions I took it away from there. That's been driving me until so far. So something that we tried to churn out from that project was what means community engagement? What are the major elements of community engagement? If you look at it from top to bottom, you have to engage with all the stakeholders and authorities. You have to have local people there. You have to understand these communities. You have to be responsive to all the community members. And you have to give some form of power. If you still take that power and do this and do that in an assertive, prescriptive way, it may not work. Perhaps we might have used some of these elements. That's why we thought this could have contributed to high population coverage. We did try to further look into whether and how community engagement helps conduct ethical global health research. basically you might be wondering, Namitaji does work in Nepal Health Research Council. People wonder how community engagement supports ethical global health research. There are list of things that community engagement helps to safeguard. For example, respecting individuals, communities, and stakeholders. Community engagement is also considered as a other side of a coin. If you go to community, in contrast to only a patient, that's community engagement. Of course, building trust and social relationship. And with community engagement, you could allocate appropriate benefits. What is appropriate benefits? You could identify risk. You could reduce burdens and exploitations. And ultimately, you could also instrumentally achieve high population coverage. So that's the sort of ethical value of community engagement. We've tried several things. This is a project in Thai-Myanmar border, very contested area, socio-politically very unstable. They did a massive mass anti-malarial administration using local human resources. These are village-based malaria workers. They were trained, and 1,300 village health posts were established to support the malaria elimination. It worked out very well. And this is, again, if you look at it from the elements of community engagement perspective, what is it using basically? What is it utilizing? Local human resources. I kept on working on this particular subject during my postdoc as well. So if you look at it, this is very theoretical analysis, something that keeps me bugging, but something that also helps me understand nowadays is how do you sort of roll out community engagement in an ethical way? You have to have a sense of working relationship with community members. You have to have the influence of stakeholders, that community feel that their voice is being heard, and researchers need to be responsive to such needs and the concepts from the community. In this respect, we did try to, this is again local human resources, we tried to utilize community health workers in Cambodia, and when trained, they can do well. You can see those blue dots are from lab technicians, and those red dots are from village malaria workers. They more or less align well, and that's what it shows in implementability of if you train community-based health workers. Again, local health workers, we've tried our best with the policymakers as well. Something I pulled out from WHO's human resources guideline. If you look at this graph, on x-axis represents the population, specifically the percentage of the population covered by health services. On the y-axis is quality of health services. Yes, you can have availability of community health workers. They could be accessible, but that doesn't ensure quality. What ensures is how do you replenish the effective coverage gap through community engagement. So that's the sort of few points that I wanted to highlight here. Again, local human resources, no doubt local human resources. This is the large project I'm working at the moment in Tanzania. This is a Star Home project. Just a tiny bit of a story while I have 40 seconds. These are free houses. One house cost $10,000 US, free, Danish architecture and German firm. They get the house for free, but people do not want to leave. They don't want to stay in that house. Even a free house is denied by community members. You know why? Lack of community engagement. So that's when I realized we need to build our knowledge from the community. That's why the term epistemic responsiveness. With this, I would conclude here that we need to learn from the community, and this is the book that I just wrote. If you are interested, I have some stories in there with diaries in global health. Thank you very much.
Thank you, Dr. Adhikari, for your presentation. Now, I would like to invite our third presenter. She is Sarah E. Baumann. She is a PhD and assistant professor, filmmaker, and scholar of participatory and critic research method with over 18 years of experience. in South Asia, particularly in Nepal. Her work focuses on advancing innovative community-engaged approaches to global women's health. She is the founder and director of the Global Women's Health Research Collective at the University of Pittsburgh and the creator of collaborative filmmaking. Her title of presentation is Exploring Key Influences of Menstrual Seclusion in Nepal Using Social Network Analysis. The floor is yours. If Sarah is not here, then I would like to invite Kritika Dixit. Okay. Our topic of presentation is healthcare providers, perception of tuberculosis-related stigma, drivers and manifest within Nepal cultural context. She is a PhD in public health and is currently serving as resource manager in Binat Nepal Medical Trust. The floor is yours, Kritika Dixit.
Thank you, I'm here. So imagine you are a patient. You have been coughing for more than 3 weeks now, and you want to go to a health center to get checked up. There are two ways you can go to a health center. One is a shorter way. You can reach in 1 hour. And one is a bit longer. There are forests, as you know, in Nepal. You have to cross the river. So which way would you choose? Shorter, right? Yeah, it's very obvious that we would all like to go to the shorter way. But if you ask me, I would say I would go a longer one. So you're wondering why, right? Okay, let me come back to you later. So good afternoon, respective chairs, my colleagues. I am Kritika Dixit. I'm the research manager at Virat Nepal Medical Trust. So since my topic has been introduced, I would like to continue my presentation. The burden of tuberculosis or TB in Nepal is very high. Every year, we estimate that there are 67,000 people who develop TB. But of them, only 60% or 1 in 2 people can access the standard government TB diagnosis and care. So what is this big missing gap? So the answers are many, as we all know, but it is not always clinical, because we have the expert biomedical tests such as gene expert machines, and the medicines for TB is free of cost. And it is also not always about access and the cost, because those who can access the treatment still suffer in silence, they delay the treatment, and they hide the symptoms. So what is the reason behind this? Yes, it is the main reason that I chose a longer journey. It is the stigma related to TB disease. And the story or these experiences is very real. These are very visible, and we can no longer choose to ignore now. So, stigma is also not an individual problem. It could be shaped by the community and the healthcare system. Therefore, understanding the stigma from different approach is very important to access the TB diagnosis and care in Nepal. So while there has been several studies that are conducted in Nepal from the patient perspective to understand the TB stigma, there is very less so from the provider's lens. Therefore, in the study, we explored the healthcare perceptions and experiences in stigma in 6 districts of Nepal. To achieve this objective, we conducted a qualitative study using key informant interviews. We did the study in 6 districts of Nepal, as you can see here in the red color in the map. We interviewed 20 TB care providers who directly provide the TB medicine and care to the TB patient. They were selected from the high notification health facilities from these 6 districts, and they were purposefully selected. We conducted semi-structured interviews. We obtained written informed consent from all the participants, and the interviews were audio recorded. We also received ethical approval from the NHRC. So all the interviews were transcribed, translated, they were inductively and deductively coded and combined into categories, which were then thematically analyzed using the 6 steps Clark and Brown's approach. So these categories were mapped using the Health Stigma and Discrimination Framework by Stengel. So, what did we find? First, the providers mentioned that there is inadequate information about TB, there is fear of identification, there is fear of transmission among the people that perceive that drives the stigma. So people with TB still associate TB with death, still associate TB with sins of past life, especially among the elderly population. So what is important or what is interesting here is that even the providers, they fear the transmission among themselves. And as I quote here, one of the providers mentioned that because they fear this transmission, they perceive their job as a very high risk job and they want to discontinue or quit their job. Second, we found that there are two layers of stigma that operated simultaneously. So one is the perceived stigma and other is the experienced stigma. So experienced stigma, meaning that people with TB directly face the experiences or example, avoidance or rejection by the community. And perceived stigma means that the anticipation of that rejection. So when a person is diagnosed with TB, the person is labeled, there is a distance made with that person by the community, by the neighbors, by the family, and there is also a non-disclosure of TB status. What is interesting here? So what is interesting is that it is the perceived stigma is more paralyzing than experienced stigma. Why? Because it is not the healthcare system that has rejected the people with TB. It is the perception of that rejection that people don't want to go and access the TB treatment. And that is why there is a lack of acceptance of TB diagnostic results. There is a refusal of TB tests. People don't want to give their sputum samples. And there is a denial of taking the medicines. So as I quote here, people even rejected the government incentive because of the fear of identification and discrimination. Third, we found that TB stigma intersects with gender, poverty, and socioeconomic status. So first with the gender. So being a woman diagnosed with TB, she carries an additional fear of being rejection by the family, rejection by her husband, rejection of future marriage prospects, and the fear of being blamed. And for a man, there is also economic ties that is related with the gender because the person can no longer work or fear that he can no longer work. And regarding the socioeconomic and ethnic minority, when a person is diagnosed with TB, then the person has to battle with all the social hierarchies and norms in our society. And it is not only the person who will be distanced or isolated, it will be their whole family and the community and from the community. So thus increasing the separation from the community, thus increasing the inequities that exist within our own community. And as I quote here, one of the female, it's very heart-pounding to say that she was sent to her maternal home for her treatment, and she changed her identity to seek that treatment. But despite so, she could not continue her treatment because of the stigma that she faced within the society, and she left the medicine and she later passed away. So these are very visible forms of stigma that we can see in the community, and these are very true experiences. So what does the provider have to say? How can they reduce the TB stigma? Yes, of course, we can make a better patient-centered care. And to do so, the providers stressed on the need of confidentiality of the disease. And this is required from the very beginning of the TB engagement with the TB program. So there needs to be build the confidence or build the engagement with the patient and also build the trust with the patient so that the person can continue the TB care. Counseling is also required. So counseling regarding taking the daily medicines for TB, also counseling regarding the awareness of TB, regarding the mode of transmission and the preventive care. Also, there is a need of person-centered care or self-care for the people with TB. So second is the awareness of TB. It is not only within the person or the family, it should be for the community. It is also not always about debunking the myths. It is also about emphasizing that TB is a curable disease so that people can come to the treatment. And to do so, the providers also stress that these kind of messages should be contextually tailored and developed and evaluated for the context of Nepal. So last is a family and community support. It is very much required, as we all know, for the physical care and emotional needs throughout the entire journey of the TB care. So as a quote here, one of the providers mentioned that if the behavior of the healthcare provider is good, then 50% of the disease problems get cured. Thus highlighting the stressing the what can the healthcare providers do from their side. So to conclude, my main takeaway message is that TB stigma is driven by and intersected with sociocultural factors among people with TB. And psychosocial counseling, support from the people and the families, gender sense is required, and TB program needs to be gender sensitive. And we all know that it is time to end TB. So with the study findings, it reiterates that it's time to end TB by overcoming the stigma so that we can provide the patient-centered care and support. Thank you very much.
Thank you, Kritika. Addressing stigma among the service providers is a critical step for TB outcomes. So now I would like to invite Sulata Karki to speak on engaging community members in co-designing intervention to address non-communicable disease risks in Kathmandu. Mrs. Sulata Karki is a senior research officer at HOD International with extensive experience in evidence-based health research. She has a strong background in mixed method implementation research, including participatory approaches, and has contributed to numerous field studies and evidence generation. Her work focuses on NCD, maternal and child health, and digital health intervention, including survey and intervention evaluation across Nepal. The floor is yours.
Thank you, Chairs. Good afternoon and namaste, everyone. I am Sulata Karki, working at HOD International as a researcher. Today, I am going to present on a topic engaging community members in co-designing intervention to address non-communicable disease risks, especially in the urban context. And I am going to share the lessons that we have learned while forming the co-production groups. Yes, to start with the background and the context, urban population, as we all know, that face lots of non-communicable disease burden and risk factors. So it has been said by numerous factors, including the individual's behavior and a complex interplay of sociocultural, economical, political, and environmental factors. So to engaging community members as equal partners enables equitable and sustainable solution to address those risks in urban context. So this work is a part of a broader study, that is the participatory engagement for city community against NCD risks, which applies a participatory learning action approach, where we have formed a community level co-production groups, and which these groups act as a co-researcher or a citizen scientist to understand and help researcher to broadly evaluate the community context, identify the critical issues related to non-communicable disease risks, and also to co-design the interventions. So this specific presentations highlights the key challenges we have faced while forming the co-production groups, and also I wanted to share the practical lessons that we have learned for meaningful engagement of community as a co-researcher. This study was conducted in 2 wards of Nagarjung municipality, Ward 9 and 10, including Ward 14 of Kathmandu metropolitan city, as shown in the map. So the formation process started with our initial proposal or thoughts of forming 3 diverse co-production groups, one with a mixed adult group of different age group, starting from age group of 18 years and above. Similarly, we also targeted to form a youth group of 18 to 24 years of age, and also a group of women with age group 50 plus or older women age groups. So we also aim to ensure the diversity of the membership in terms of age, education, sex, occupations, ethnicity, disability status, location, and also resident types, to form a diverse membership within these co-production groups. So the consultation process started with the iterative process of consulting with the local gatekeepers or the community stakeholders, which was then followed by the group discussion with local gatekeepers, where we have engaged a number of representation from the community and the municipality or a local level, which included ward chairperson, municipality representatives from health facility, from school, local club members, etc. So initially what we did was we compiled a list of the existing co-production, existing networks or the community groups that has been functional or available in the community, and then we divided the study area into small subclusters so that we can pull the few members from each group to ensure the area-based representations, and then we contacted the lead or a chairperson of the group for the participant identification process. So as a part of the pre-formation engagement process, we approach the selected individual identified by local gatekeepers, and then we inform over the phone and also repeatedly visit to the community to help understand about the project, overall objective of its process and time commitment through the entire 3 years duration of the project. We also assure and assess their willingness to participate in the study as a voluntary participation. And during the entire formation process, we always thought of forming the groups, ensuring the diversity for the equitable participation. So after then, we have formed a co-production group of 3 diverse group, and then we hold a meeting or conduct the meeting with these 3 subgroups, where we formally discuss the study objectives, discuss the roles and responsibility of their participation in this project, and then agree some group principles, and also we obtain the written informed consent to work as a co-production groups or a citizen scientists in this study. So as a result, we form members of 53 members as a citizen scientist to work with us, with the researcher, and help in designing the interventions. So these are the pictures of those group. This table shows the summary and summary of the socio-demographic profile of the participant, where we have considered the diversity in terms of age, range, sex, ethnicity, religion, education, occupation, and also by resident types, where we have included members from the rented household, and from the education category there were also from highly literate groups to the illiterate groups. And also in terms of ethnic composition, we try to include the members from the minor ethnic groups as well. So the main challenges of forming the co-production groups and during this formation process was, in urban context, the population are often mobile and they are quite busy. So there was a frequent movement of their work for all the healthcare, and also there was the issue of the migration. Another challenge we faced was there was a low participation from the rented household, because they thought and they were quite reluctant because of their short-term stay and limited community interactions. Also, they were uncertain about their commitment to the project. Therefore, the key lessons we have learned was like utilizing the existing community groups and mobilizing the members from that groups was quite feasible to make co-production groups, and we also allowed some replacement over the time. Otherwise, it will be very hard to sustain the groups throughout the study duration. So now the challenges we faced was like recruiting the youth participation, youth members in the group. Especially they were like busy with their school life or college life, and they were reluctant to participate in terms of their time commitment. And they have also frequently mentioned us that they are planning to move to abroad, so we couldn't commit to this project. So it was quite hard for us to include especially youth members as a co-production groups in our process. So one of the key lessons we have learned and what we have deal with these challenges was we adopt the peer-led process, so that we could so that the identified participant helped to recruit other participation. So peer-led process was quite useful. So another challenge was gender roles and imbalance that was like led by the male participation, which was often limited by the work responsibility, and women participation by limited by the household responsibility. And there was also initial discomfort among the mixed gender groups. So to deal with these issues, we have like gender segregated group discussion led by male researcher to the male participant and female researcher to female participation in the later stage when we deal with these challenges. And there was also a difficulty in including the minority ethnic community, though we tried our best to include the participant from minor ethnic group, but it was quite hard. And also the representation in existing community groups were from the upper caste group. So the ultimate lesson we have learned was like the iterative, consultative process with back and forth talks and informal, formal conversation with local gatekeepers and community members, also like reaching out the individuals in the community. So it was a quite hectic and a long process to form the co-production groups. Another challenge was it was difficult to include the people with disability also, because they were quite reluctant to participate. And so to deal with these issues, we have like included caregivers. At least 2 caregivers are included as a co-production group members to include their voice in our study. And another was biggest challenge was ethical concern, though some of the participants were quite interested to participate, but it didn't allow because of their age group. It was also a case of the disabled people who was interested but couldn't include in our groups. So another one of the key facilitating factors was compensation. We did provided few minimal incentives for their time commitment and also the communication allowances, so as to include the marginalized group in our co-production groups formation process. So finally, to conclude, formation of the co-production group in urban context with diverse participation and being inclusive was very hard, but we try our best to include at least few members from the diverse community in these settings. So finally, the take-home message is flexibility is critical. What we did was to balance or manage the urban mobile population. We prioritize their time against our. So we did the meeting, especially in the off hour. Above 5 or in the early morning, and also we have like conducted discussion in weekends, even in Saturdays. Mostly we have conducted the discussion in Saturday. So inclusive participation requires careful planning, intersectional considerations, and iterative consultation process. And also compensation has helped to engage marginalized community groups to include in our co-production group members. And also the shared ownership with the local municipalities has helped us to work closely with the community to help better understand the context and also to design the interventions, which we are planning to do in upcoming
Thank you.
process. Thank you very much.
Sulta. Very nice presentation. We now invite Rajan Shrestha. His title is Effectiveness of Female Community Health Volunteer-Led Physical Activity Promotion Intervention in Semi-Urban Area and Open Level Cluster Randomized Trial. Shrestha is a PhD researcher at Aarhus University, currently working in Nepal Development Society, working on physical activity, epidemiology, and community-based intervention. In Nepal, his research uses accelerometer and other measures to understand movement behavior and inform scalable strategies for NCT. Over to you.
Thank you, chairs, and namaste, everyone. Thank you for having me here. I'm sharing the findings of my PhD project that is on effectiveness of physical activity intervention in Nepal, and the physical activities measured using accelerometers as outcome measure. So physical activity is well established as beneficial for health. However, there are around 1 in 3 people in the world who does not meet the recommended level of physical activity recommended by WHO. That is at least 150 minutes of at least moderate intensity per week. So that is the problem globally. And during these 2 decades, there are no progress in decreasing the prevalence of physical inactivity, even though there are lots of activities going on. So yeah, However, the small increase in physical activity is beneficial for health. So, in talking to Nepal, the physical activity in urban areas is declining, and the similar is true for semi-urban areas as well. However, there are different statistics. In our national survey, it is around 7 to 8% physical inactivity prevalence. But if we go to the semi-urban areas, it is up to around 43, 44%. So there are disparities in evidence as well. And it is also positive evidence are there in terms of physical activity interventions. So we also does not have enough information on the effectiveness of physical activity intervention. So we engage these female community health volunteers who are well known to us. They are effective in supporting maternal and child health in Nepal, as well as they are also engaged in NCD management these days and found effective in managing hypertension, diabetes, cervical cancer, and other non-communicable diseases as well. So we also engage these human resource for health in Nepal and tested the effectiveness of their engagement in promoting physical activity in semi-urban Nepal. We did this using cluster randomized control trial. It is done in the previous Leknath municipality. Now it is in merged in Pokhara metropolitan city, and we recruited 264 adults from the study site using 1:1 ratio, and our intervention duration is for 6 months. Yeah. The intervention was designed using co-design process, and we engaged two type of personnel in our co-design process. So the first first workshop we conducted among the experts, and we engaged health educators, public health researchers, physiotherapists in the expert level workshop, and in user level workshops we engaged the local people from the study site, and we also engage FCSBs and health workers working in local areas. And we develop our intervention based on theory of planned behavior, which have different constructs like attitude, subjective norms, perceived behavior control, and intention for physical activity. And all those construct is transferred to the physical activity behavior. So our main idea is to motivate them and try to increase their attitude, subjective norm, intention towards physical activity, so that the physical activity level of the participant is increased. So that is our idea of our intervention. And we did this through a home-based visit. We conducted this in 3 home-based visit, 1 visit per month for 3 months, and that was done by the FCSBs who were trained for doing that community-based physical activity intervention in that area. And we assess our outcome using accelerometers, and we use the accelerometer called XGVT AX3, that is from UK. And the participant needs to wear it for 7 consecutive days, 24 hours a day. And we gave them the wrist-worn accelerometers and collected it in 9 to 10 days. So whole 7 days they need to wear it. And our primary outcome is change in daily moderate to vigorous physical activity minutes per day. And there are secondary outcomes as well: the light level of physical activity, sedentary time. We also look at the quality of life, sleep quality, and total duration as well. So there are altogether 15 clusters in the study area. However, we excluded 1 and included only 14 clusters. And from the 7 cluster in each, we recruited 132 participants in each clusters. And we have around 82 to 84 follow-up rates in our intervention, in our trial. And there are 4 participants in each group who we need to exclude them due to lack of the valid wear time. And the valid wear time we use was they need to wear at least they need to have at least 3 days valid wear time, and the valid wear per day is they need to wear they need to have valid wear data for at least 23 hours in 24 hours. So at least if they have 3 days of valid data, we included them, and the 8 they does not meet our inclusion criteria. So talking about the effectiveness, this is our main outcome. The interesting thing is that both group has declined their physical activity level in inline survey compared to baseline. So physical activity level is declined in both group. However, the decline is small in intervention group, and the net change, the difference is 9.8 minutes per day in non-bout physical activity, and around 5 minutes in 10 minutes bout. 10 minutes bout is the person needs to be engaged in physical activity continuously for at least 10 minutes. So if he or she is engaged for at least 10 minutes physical activity, then we considered it as 10-minute bouts. And in previous WHO guideline, it is included that. So looking at the subgroup analysis, the only hypertension subgroup is significantly different. Otherwise, other subgroups we don't find any significant changes. So there are other secondary outcomes. The average acceleration, that is also declined in both groups, and sleep quality has improved in both group. And other than that, other secondary outcomes, we don't see any significant changes. So in conclusion, our hypothesis of increasing physical activity is not made. So our intervention could not increase the physical activity level. However, we could slow the decline over time, which is also very important in our settings where the urbanization, changing lifestyle. We say that the decline, if we could avoid the decline, that is also beneficial for our health. So the small difference is also very beneficial for health. And yes, the FCSVs who are engaged in our interventions, they can do the physical activity intervention effectively. And the simple home-based physical activity education can make a big difference. So yeah, this is our findings. Thank you for listening. Yeah. So
thank you, Mr. Shrestha. Now I invite Amy Gray to present contextual influence on the implementation of community-based oral health program in rural Nepal. Amy is a doctoral candidate at the University of Montana of the United States and a visiting Fulbright fellow with Kathmandu University School of Medical Sciences and Dhulikhel Hospital. Amy has a background in clinical dentistry, public health, and nutrition, which has driven her passion in pursuing improving access to culturally tailored healthcare services in rural communities. The floor is yours.
Hi, thank you for that introduction. So again, my name is Amy Cicillo. I'm a PhD candidate in public health at the University of Montana in the United States, and a visiting Fulbright Fogarty Fellow with Kathmandu University School of Medical Sciences, Dhulikhel Hospital. So I'll be sharing findings from our study today, contextual influences on the implementation of a community-based oral health program in rural Nepal, a mixed method study. Starting off with some background information, it's estimated that nearly 3.5 billion people suffer from untreated oral diseases globally. These diseases include tooth decay, gum disease, edentulism, or a condition of having no natural teeth, and lip and oral cancers. Now, important to understand when we talk about oral diseases, they are linked to many systemic conditions, including but not limited to heart disease, diabetes, adverse pregnancy outcomes, as well as a decreased quality of life. When we look at the burden of oral diseases, we can see that they're not evenly distributed across populations. 3 out of 4 people impacted by these diseases live in low and middle income countries. One of the challenges driving these disparities is the concentration of dental providers and facilities in urban areas. And this is particularly apparent here in Nepal, where it's estimated that most dental providers are concentrated to the Kathmandu Valley, leaving rural communities with little to no access to oral health care. So the basic package of oral care, or the BPOC, was developed in 2002 and endorsed by the World Health Organization as a cost-effective and minimally invasive approach to providing basic oral health care services in community settings with a flexible workforce. This is the intervention that our study focuses on, and since its development in 2002, few studies have explored how this model is implemented in community settings, leaving us with limited insight on how to deliver it. So in partnership between local governments and one non-governmental organization, an augmented basic package of oral care called the BPOC Plus is being delivered across 7 municipalities and 26 wards in the Gandaki province. The BPOC Plus is delivered through existing primary healthcare facilities, school, and community settings. So the objective of our study was to describe the implementation outcomes and contextual influences of the BPOC Plus using the practical, robust implementation and sustainability model and the re-aim outcomes, which are reach, effectiveness, adoption, implementation, and maintenance. So we conducted a sequential explanatory mixed method study to achieve this objective. And we did this within the principles of community-based participatory research. And this is our implementation model here, situating the quantitative and qualitative phases of the study. So the design calls for the quantitative phase first, and we can see that this focuses on these re-aim outcomes. So we assessed existing program records to describe each implementation outcome, and then we utilized findings from this phase of the study to inform our qualitative phase of the study, which this phase of the study consisted of 2 components. We captured organizational perspectives using semi-structured interviews with staff members of the implementing organization. And then parallel to the interviews we explored community or participant perspectives using an audiovisual participatory method called photo voice. And then in one final phase of the study, we integrated the findings to describe each implementation outcome alongside of contextual influences on those outcomes identified in the qualitative phase. So diving into our results, we analyzed service delivery patterns between 2023 and 2025, as well as the allocation of public funding between 2020 and 2026. We conducted interviews with 22 staff members of the implementing organization, and we conducted a photo voice study with 10 community members in 1 rural municipality currently implementing the BPOC Plus. The rest of our results are organized by the re-aim outcomes. So starting with reach, we wanted to understand who the program is reaching. So quantitatively, we saw an increase in program reach between 2023 and 2025. And then our qualitative findings added that services were effectively reaching marginalized groups, and that this was facilitated by the delivery of 4 distinct program activities across those primary healthcare facilities, school, and community settings. And then a quote from a community member in our photo voice study described this concept well. Previously, the poor and suffering did not have discount to dental health, but now in every community, the poor and suffering have access to free health services. Okay, next we have effectiveness. And for effectiveness, we wanted to determine if the program was effectively providing more preventive services when compared to services that intervene in a more advanced disease state. And we did observe that service delivery favored prevention, and then qualitative insights added that behavior change attributed to the BPOC Plus model allowed for the provision of more preventive services over time. Another quote from a community member in the photo voice study really highlighted this concept. This photo shows an increased habit of going to the doctor for health checkups. It makes it easier to detect and treat diseases on time. This change has raised health awareness and with timely treatment helped prevent serious illness. For adoption, we assess the allocation of public funding for implementation, and as we can see here, there was an increase in both the number of municipalities as well as the amount allocated to implementation. And then a program administrator provided this quote that gave us some more insight into the role that public investment plays on adoption. If they allocate a budget, then we can add services. It is a partnership. If they cannot allocate a budget in their meetings and they say, no, we cannot, then only our initiative is not enough. For implementation, we looked at the consistency of activities across municipalities and years. Quantitatively, we did observe that there were some inconsistencies in the number of activities that were conducted. And then our qualitative findings, a program administrator provided this quote that probably partially explains some of those inconsistencies. The reason we cannot reach in 6 months is sometimes leave issues, sometimes budget issues. Because of not being able to reach every 6 months, they say, you tell us 6 months, but you don't come. And our final outcome here is maintenance. We did not assess any new quantitative data for this, but we did observe the increase in reach and adoption of the model since 2020, demonstrating a degree of sustainability. And then maintenance also includes long-term impacts on individuals. So we had a program administrator that discussed some of those long-term impacts in this quote. And I think that's a really positive aspect of the program, because regardless of the clinical care that gets done, you're setting people up to trust this system. You're setting children up to not be afraid to go and see a dentist. If that's all you do, that's a huge contribution to their future participation and their own well-being. So in conclusion, consistent with previous literature, these findings underscore the substantial impact of multi-level determinants on program outcomes and highlight the need for community-based oral health programs to address multi-level determinants through implementation. To our knowledge, this is the first study that has applied an implementation model to comprehensively explore both organizational and community perspectives alongside of implementation outcomes of the BPOC as an oral health intervention. And findings from this study will inform adaptations to the existing program in Nepal, as well as future iterations of community-based oral health care in other rural settings globally. And first and foremost, I would like to acknowledge our community members, participants, and community advisory board who helped us co-create this knowledge. And then this work was supported by the U.S. Department of State and the Fulbright program, as well as the Fogarty International Center of the U.S.'s National Institutes of Health. Thank you.
Thank you. Thank you very much, Amy. We now invite Dr. Ratna Mishal. Our topic is effectiveness of 3 manual toothbrushes with different bristle design in terms of plaque and removal of gingival inflammation, a randomized control trial. Dr. Ratna is a BDS, MDS graduate from BPKHS, Dharan. She has a 2-year scholarship born on Madan Bhandari Hospital and Trauma Center in Morang and is currently a lecturer in public health dentistry at Kathmandu Medical College and Teaching Hospital in Dwakot. Additionally, she is a permanent member of NMA, NDA, and NADR. Over to you.
Thank you. Good evening, chairperson and everyone present here. I'm Dr. Ratna, and I'm really honored to present my one of my research in the National Summit of Health and Population, and I would like to thank NHRC for giving me this opportunity. So. So my research topic is effectiveness of 3 manual toothbrushes with different bristle designs in terms of plaque removal and gingival inflammation or randomized control trial. So they are my authors. So what do we know about the dental plaque and which causes the some side effects, some deleterious effect in our oral cavity. So starting with the dental plaque. Dental plaque can be defined as the soft deposits that form the biofilm adhering to the tooth surface and other hard surfaces in oral cavity, including the removal and fixed restoration. So it is primarily composed of microorganisms. So 1 gram of plaque contains approximately 10 to the power 11 bacteria, when typically it accumulates if there is no oral hygiene measures applied. So the plaque accumulation can cause mainly two effects, that is gingivitis and periodontitis. So plaque removal is essential. So we can do plaque removal by two methods, either chemical and manual methods. Mechanical or chemical methods. So in mechanical methods we do manual toothbrush or power toothbrush, but in our underdeveloped countries manual toothbrush is mandatory and it is most commonly used. So there are various factors which influence the effective plaque removal in manual toothbrush as well, which is the design of toothbrush, the skills of individual, the toothbrushing frequency and duration. When we keep those last four factors constant, we can see the effect of design of toothbrush in the plaque removal. So why did I do that in this research? Because there are lots and lots of toothbrush added in market every day, but there are various research as well in this topic. Having said that, the results are conflicting. Some studies said some designs are superior, but in general, most of the studies say that there is no superior design of toothbrush for plaque removal. In our country, till that day, there were no such studies regarding this topic. So this result also guide the dental professional and general people to choose the manual toothbrush for the better oral hygiene measures. So this is my objective, to compare the effectiveness of 3 bristle design toothbrush in plaque control and reduction in a gingival inflammation among the undergraduate girls students. So to achieve the objective, what I did was we conduct a randomized control concurrent parallel study in the undergraduate girls student in girls hostel of BPKHS Dharan, and it was done in April 2021. So ethical approval was obtained from IRC BPKHS and NHRC itself. The trial registry was done in Nepal Clinical Trial Registry platform. So the ineligibility criteria, the individual having plaque and gingival score at least 1, and individual having at least 5 teeth in each quadrant with facial and lingual scorable surface were included in this study. And those individuals with systemic illness, orthodontic appliances, who requires emergency dental treatment and advanced periodontal disease, history of using antibiotics and any prophylactic agents were excluded from the study. For sample size, considering 10% autism rate, we got 35 in each group. And we have also done the randomization. The total of 105 eligible participants were selected, and the students were divided in 3 groups, 1:1, 1:1, and they were assigned in to group A, B, C for various toothbrush. Allocation consignment was done by an assistant not participating in the study, who had prepared the sequentially number opaque sealed envelope, and participant picked the envelope according to the sequence, and based on the assigned group, respective treatment was carried out. This study was double-blinded study where the analyzer and examiner were blinded. Before this, I want to say in disclaimer that I am not promoting any brand here, because I had used this brush because these are readily available in market. So I use these 3 toothbrush: Oral-B Pro Health, which has crisscross design; Oral-B Shiny Clean, which has zigzag bristle design; and Oral-B Sensitive Care, which has flat bristle design. These are the toothbrush I have used. We can see the arrangement of bristles in various toothbrush. We can also see the in the side view of toothbrush. Along with the toothbrush, I had also provided the for uniformity fluoridated toothpaste at the baseline to every individuals. These are the instrument I have used. So this is me demonstrating the toothbrushing technique. We recommend the individuals to brush for 2 minutes 2 times a day, after breakfast and before bed, for 2 minutes for 21 days for the end of the studies. This is me collecting the data, doing the examination. And in measurement parameter, the overall mean score of plaque index and gingival index were measured at baseline 7 days, 14 days, and 21 days. So these are the coding criteria for plaque index. These are the tool for gingival and plaque removal and gingival index. These are the interpretation, and this is how we do the plaque index scoring. This is the gingival index scoring criteria, and these are the interpretation: mild, moderate, and severe. And this is how we do the recording of gingival index. So in result, we examined total of almost 340 girls students, and out of which 105 participants were who had met the eligibility criteria were included and randomized in 3 groups. So this is the consort flow diagram, where we can see that 105 students were randomized in 3 groups, and they were examined in baseline, and then after 7 days, 14 days, and 21 days. And there were lost to follow up also. In group 1 there were 11 students lost to follow up, and in group B 8, as well as in group C. So at the end of the study, there were only 78 students. So the majority of participants were MBBS and final year students, and the mean age of the participant was 22.61. So this table shows the plaque score of toothbrush at different follow-up. We can see that various toothbrush designs decreases the plaque score from baseline to week 3, and which is statistically significant. Similar finding we can see in the gingival score as well. We can see that these 3 toothbrush has decreased their score from baseline to week 3, and this was significant. In this figure, we can see the intergroup comparison of plaque index score at baseline and follow-up. We can see that zigzag toothbrush, the blue line, has marked decreased as compared to crisscross and flat toothbrush. A similar finding we can see in gingival score as well. So in conclusion, I want to say that all 3 toothbrushes showed the reduction in a plaque and gingival score over the period of time. Though the zigzag brush showed marked reduction in both score, however, difference was not significant. So this study strongly suggests that the use of manual toothbrush practice must be practiced for oral hygiene maintenance. So in our underdeveloped countries, we cannot use power toothbrush. We cannot recommend power toothbrush to everybody. So in manual toothbrush, we have the recent advancement in bristle design. So I highly recommend that advanced toothbrush has higher efficiency and beneficial effect than the conventional one. So saying this, I want to conclude my research. Thank you.
Thank you, Dr. Ratna, for those practical findings on everyday health tools. Now, I would like to invite Susmita Neupane to present health system factors influencing the implementation of physical activity information provision in antenatal and postnatal care services in Nepal. She is a PhD candidate at the University of Bourgeon, working on the I Prevent NCD project with a focus on promoting physical activity during pregnancy and the postpartum period in Nepal. She has over 5 years of experience in the health system and public health, particularly in monitoring and evaluation of health programs. The floor is yours.
Thank you, Chairs. Good evening, everyone. I am Susmita Neupane, a PhD candidate. Today here presenting few of my findings on health system factors affecting physical activity provisions among pregnant and postpartum women in Nepal. This research is a part of a larger project called I Prevent NCD, which employs a life course approach to the prevention of NCD risk factors. And this project is led by Norwegian Institute of Public Health with Dulikhel Hospital and NHRC as partners in Nepal. So we are authors from Australia, Norway, and Nepal for this research. So starting with the background, we know that physical inactivity is one of the major risk factors for non-communicable diseases, including cancer, hypertension, diabetes, just to name a few. And conversely, physical activity helps prevent and manage those diseases. And World Health Organization guidelines recommend 150 minutes of physical activity per week for population across all gender and all ages, including for pregnant and postpartum women, which means physical activity is not only considered safe but is also beneficial in that period. Physical activity during this period not only provides the immediate birth outcomes but also reduces the risk of future NCDs, not only among these women, but also their offsprings. However, despite these significant health benefits, physical activity during pregnancy and in the postpartum period decreases. And yes, there are interpersonal, socio-cultural determinants to it, but health system plays an equally important role in enabling physical activity. However, there are limited evidence on how health systems in Nepal support or constrain this behavior among the women. So, we conducted a study to explore how physical activity during pregnancy and postpartum is addressed in the federal, provincial, and municipal policies and guidelines, and how health system factors affect physical activity related information provisions, also referred to as counseling, by health workers within the routine antenatal and postnatal care services. For this, we conducted a qualitative study in 3 districts of Nepal, Gorkha, Nuakot, and Sarlai, representing the 3 diverse districts of Nepal. We conducted focus group discussions and key informant interviews among healthcare workers, policymakers, and program managers across federal, provincial, district, and health facility level. We reviewed documents related to non-communicable diseases and maternal health, and then applied a framework analysis using WHO health system building blocks to analyze the data. And what we found is that physical activity among pregnant and postpartum women is not a system priority. Yes, the federal, provincial, and even municipal policies emphasized on yoga and open gyms, and also opportunities like sidewalks and cycle lanes. But there were no community-based interventions targeted to encourage pregnant or postpartum women for physical activity. And as said by one of the health section chiefs, since the Nepal government has not allocated a budget for this specific area, it seems that physical activity has not been prioritized for our target population. With competing priorities, limited resources, and no dedicated fundings, physical activity promotion has not been able to be institutionalized at the local levels, further limiting it for the pregnant and postpartum women. And going through the documents and analyzing the data from FGDs and KII, the only intervention for pregnant and postpartum women, it was limited to the counseling practices at the health facilities by the ANMs. But as one of them shared, we do not have references or guidelines to show normal or CS deliveries can do what exercises and since when. So there is a lack of operationalized guideline. Yes, we have the clinical guidelines that ask health workers to counsel women on physical activity throughout their pregnancy and after 6 weeks of postpartum, but still the health workers did not find it helpful to provide tailored counseling. They also lacked specific training for physical activity counseling, and with the lack of training and operationalized guidelines, they have been working based on what they learned and also referring to their supervisors. So this all led to a very vague and blanket counseling that was to avoid heavy working, keep doing the household chores, and keep walking. We further found a very weak integration of physical activity within the existing health system. Earlier when I talked about training, only the health facility in charges were sent for the pain training, and that was not practiced in the ANC and PNC care services. And the IEC materials that could have been used for counseling that were not available for the ANMs. As one of them said, about non-communicable diseases, it might be there in the OPD. The sisters might have it in OPD. So even if there were some ICD materials that belong to the outpatient centers and the ANMs did not have access to it. Further, physical activity counseling was not integrated in the reporting and hence was easily deprioritized during the ANC and PNC services. And since it was not, the physical activity levels were not recorded or reported, it was easy to deprioritize at the higher levels because there were no evidence showing that the physical activity levels declines in this period, and there is a need to do something to help this woman. So to conclude, physical activity during pregnancy and postpartum in Nepal is constrained by both weak prioritization, guidance, and system integration. And physical activity information provision or counseling in the health facilities can be improved with strengthening guidelines, ensuring access to the job aids or the counseling tools, and further strengthening supervision and reporting systems. It is important to acknowledge few of the limitations and strengths we had while conducting this study. We have discussed a lot about counseling or the information provision, but our study lacks observation. And with only the FGDs and KIIs, there is a risk of social desirability bias. And being a qualitative researcher, it's important to acknowledge our positionality. I, as a main researcher, was born and raised in Kathmandu. I have a public health background, have been working in few of the districts of Nepal in health system and maternal health. So I had some assumptions regarding the rural lifestyle and the physical activity levels among the women. And so did the other researchers, as many of us were from Nepal. And so we kept each other in check with regular peer debriefing and maintaining transparency throughout this study. And we also triangulated our data to strengthen it with the documents review. Yes, and that's all I have for today's presentation. And I'd like to thank Tullikhel Hospital, University of Queensland, NIPH, and CQ University of Australia. Thank you so much.
Thank you, Sushmita Nepaniji. Wonderful presentation. I now invite Professor Dr. Archana Shrestha, invited speaker. Her title is Overview of Implementation Research Guideline. Dr. Archana is a professor and director of public health program at Kathmandu University School of Medical Sciences. She plays a key role in advancing public health education, research, and program development. Dr. Archana, over to you.
Good evening, everyone. I hope you still have some energy. I know it's a long day. So today I will be talking about the implementation research training manual that we developed in collaboration with the Nepal Health Research Council. Looking for some people who contributed, but I don't see anyone, so no worries. And then the background is we are trying to strengthen national capacity for evidence to practice translation within Nepal. Just to give you a very, very quick background on implementation science. This is one of my favorite pictures. It says that the latest research shows that we really should do something with all of this research. And even when we look at the history, there is a clear evidence of research to practice. If we look at, today it's very obvious, like vitamin C prevents scurvy, but when we look at in around 1600s, lemon juice was shown to prevent scurvy, but it took like 194 years to bring that knowledge into practice. So there has been a lot of gap. A group did this really wonderful analysis that really kicked off implementation science. And then they showed that it takes about 17 years to turn only 14% of the original research to come to the benefit of the patient. And this was like very alarming. And then I think this really ignited a big discussion of like where we should be heading towards and gave rise to the popularity of implementation science. From the perspective of public health impact, the ultimate impact of the implementation of a public health program depends on two things. One, effectiveness, and we always doing effectiveness study. So we are looking at interventions, and we see doing like very rigorous randomized control trials, and then we see that, okay, it's doing something for improving health, but actually to really improve the health, it has to reach to the specific population. So there is these two dimensions that are playing a big role. I would say like there would be much more other dimensions as well, as Amy also presented a few minutes ago, how the implementations, how are they implemented, like what is their fidelity, how are they adopted by the health system, and so forth. So like just to give you a very brief implementation science definition, we are obsessed with definitions in Nepal. So implementation science is the scientific study of strategies that facilitate the uptake of evidence-based practice or evidence-based interventions and research into a regular use by practitioners or policymakers. It can be in clinic or in a public health setting, in primary healthcare setting, Ministry of Health, anywhere. So if we also look at the pathway of research, we first start with pathophysiology research. Then we go to our favorite, like development of diagnosis and what intervention works, what does not work. Then we move towards how do we actually best deliver those interventions. And that's where the implementation science scope really begins. And then we want to really scale up. So we want to ask, does this intervention and delivery model really work, and how to make it work? So, however, there is a very limited capacity, I would say, both at national and international levels, specifically in the low and middle income countries. Many researchers have not been trained. So I was trained in both Nepal and the US, and during my own course of training, I didn't get any training on implementation science as a student or as a practitioner. So there is a very limited ability to design such kind of contextually sensitive interventions, and also finding out the appropriate implementation strategies and really test whether or not those delivery mechanism works. And to make things work, health system is very complex, and it is influenced by like a multiple contextual factors. So we need to understand that and take that into account as well while we are delivering these proven interventions into the public health practice. So one teeny steps towards that is development of this training manual and implementation research, and I have no intention to take credit of that. I was one of the team members, and I'm presenting on behalf of the members who were involved in development. So the goal of the manual was to actually strengthen the capacity of researchers, trainers, public health professionals in planning and conducting implementation research. There are many implementation research training manuals and guidelines and materials that has been targeted and developed in high-income countries. And if you look at those, as we are emphasizing a lot in context, they have not been contextualized in the context of Nepal. So we wanted to introduce the fundamental concepts like frameworks and principles of implementation science within the context of Nepal, and then build the capacity of people here to conduct a high quality implementation research, understand the contextual factors, promote their skills to selecting strategies and measuring the outcomes, and strengthen their abilities in stakeholder engagement to conduct all of these research. So we developed in these steps. So we started with forming a working group, then developing a preliminary draft. Then we did a couple of consultative workshops, finalization and publication, and then we tested the manual. So one big step was to form the working group with experienced researchers, academicians, and subject matter experts. And then these experts put together one preliminary draft. And then the draft were put together based on existing literature, global practices, relevant national and international guidelines. And we also pulled together a lot of field-based experiences. We actually pulled together the implementation researchers who are doing such kind of work in Nepal, and then we brought their examples together to develop the first preliminary draft. Then we did 4 consultative workshops for refinement, and then each workshop had specific aims. So first workshop was mostly focused on a review, overall structure, theme, technical content, and if there was key gaps. Second was emphasized on improving clarity and contextual relevance. Third was emphasizing aligning the manual with case studies and group work. That was the most like longest workshop among these four. And the last was we did an in-depth review and built consensus, and then addressed all of the feedbacks and came up with our final version. Then we finalized the version and then published it. We did like some editing, quality assurance, and published it. So final training manual was then had 9 modules: introduction, implementation outcomes, contextual determinants, strategies, engagement of stakeholders, designing research to identify contextual factors, designing research to test the strategies, ethics, and reporting guidelines. Then we move forward in testing the implementation manual, which was quite a big leap for us. It was a 6-day intensive training workshop where 113 MPH students across Nepal from 9 universities participated. It was a learner-centered, experimental, experiential, pedagogical approach. We had short didactic lecture, and it was followed by smaller group discussions where students or trainees developed their own research protocols. So they developed 2 protocols. So one was on identifying the contextual determinants, and another was on testing the implementation strategies. And then they all used a case study that we had developed for this course on cervical cancer prevention. And then we also found some significant improvement in their knowledge. We yet to see if they would be applied or not. Before and pre, we did training score and post-training score and compared the difference, and there was a significant improvement. We also asked the participants to evaluate the manual. They were handed over written. They were given a paper to give us a written evaluation for the workshop, as well as the material, and some of the positive and negative things that they highlighted was like there was a high level of satisfaction with the workshop's relevance and structure and facilitation, whereas they also felt a little bit overwhelmed with the content and its intensity. So for the next steps, we are announcing an implementation research workshop to develop more capacity in this area. We are also announcing 5 grants for the students who took this training, so they would be able to apply the skills that they have used, they have learned in the workshop. So these were the writing team. These were the participants from the consultative workshop, and thank you.
Thank you, Professor Dr. Archana Shrestha, for providing a clear overview of implementation research training manual. Now I invite Mrs. Bala Rai to present Advancing Health Promotion in School, Evidence and Practice. Mrs. Bala Rai is a Senior Hospital Nursing Administrator at the Nursing and Social Security Division. She plays a key role in nursing leadership and healthcare administration, contributing to the effective management and delivery of nursing services. The floor is yours.
Thank you, Radhika ma'am. Respected chairs and all valued guests over here. यहाँ सम्पूर्णलाई सन्ध्याकालीन नमस्कार. मेरो प्रस्तुतिकरण विशेष गरी अध्ययनसँग भन्दा पनि जुन एभिडेन्स हामीले जेनेरेट गरेको छौँ ग्लोबली पनि त्यसको आधारमा हामीले के गरिरहेछौँ प्र्याक्टिस भन्ने विषयवस्तुमा केन्द्रित भएर यहाँ ल्याएको छु. सो यो हेल्थ प्रमोटिङ स्कुलको हामीले ब्याकग्राउन्ड हेर्दै जाँदाखेरि स्कुल भन्ने बित्तिकै एउटा त्यस्तो प्लेटफर्म हो जहाँ देयर इज education and there's health, and then we can create that environment, and there's an opportunity when we come together, and then we can improve health and also the learning outcome. So त्यो opportunity हामीसँग छ. त्यो सँगसँगै we do have some challenges, but not limited to this, but अरू पनि छन्. जस्तै we have the high burden of childhood disease, and there are risk factors as well. अनि पहिलेको प्रस्तुतिकरणमा हामीले के देख्यौँ त भन्दाखेरि चाहिँ we talked about the NCDs, we talked about the oral health as well, हैन. So I think त्यो कुराहरू चाहिँ एभिडेन्सले भन्दै आएको छ कि yes, we do have challenges, and then NCD is always there, and then traffic injuries, violence, drowning, and mental health, and also the teenage pregnancy, which impacts the mental health and also the learning outcomes of the students. Now, so having that opportunity, and again there are some challenges as well. So I think this is the model what we want to talk and discuss in this 10 minutes presentation. So this is the concept of health promoting school, which was started from WHO, and then there is a whole school approach which engages school, family and the community as well. So हामी यसलाई नेपालीमा चाहिँ स्वास्थ्य प्रमाणात्मक विद्यालय भनेर यसलाई त्यही अनुसार चाहिँ कार्यक्रमहरू हामीले विस्तार गरिरहेका छौँ, र जसमा इट्स एन लाइक अ सिम्पली यसलाई हामीले परिभाषामा जाँदै गर्दाखेरि चाहिँ एउटा त्यस्तो ठाउँ हो जहाँ विद्यालयलाई हामीले चाहिँ लर्निङ इन्भाइरोमेन्ट पनि क्रिएट गर्ने र सेफ र स्वास्थ्यकर इन्भाइरोमेन्ट हामी बनाउनु सक्नुपर्छ भन्ने हिसाबमा हामीले यसलाई अगाडि बढाएका छौँ. एन्ड देन जस्ट अ क्विक रिभ्यू, वाट आर द ग्लोबल स्ट्यान्डर्ड्स द्याट एक्जिस्ट फर दिस हेल्थ प्रमोटिङ स्कुल. You can see there are 8 of the components which defines the standards of health promoting school, and starting from the government policies and resources, of course there is school policies, there is school governance and leadership, and also the school partnership. These 4 standards are basically the governance structures and the partnership. And you can see there is a small rectangle over there. There are the remaining the 5th, 6th and 7th and 8th standards, which is more focused on the school operation. यो चाहिँ विद्यालय भित्र गर्नुपर्ने विशेष जुन मापदण्डहरू छ त्यो चाहिँ 5, 6, 7, 8 नम्बरको छ, जसले स्कुलको करिकुलमलाई पनि समेट्छ. त्यसै गरी चाहिँ सामाजिक भावनात्मक वातावरणको कुरा पनि गर्छौं र विद्यालयमा हुने स्वास्थ्य सेवाका कुरा पनि गर्छौं भने भौतिक वातावरणको कुरा पनि गर्छौं. सो यो 4 वटा जुन कम्पोनेन्ट यहाँले देख्नुहुन्छ 5 देखि 8 को, त्यसले चाहिँ विशेष गरी चाहिँ हेल्थ प्रमोटिङ स्कुलको विद्यालय भित्रै गर्न सकिने मापदण्डको बारेमा पनि व्यवस्था चाहिँ हामीले यसमा चाहिँ गरेको छौं. सो फलोइङ दिस all the 8 global standards for health promoting school, we also have adopted it. Now the evidence what we have, यो धेरैवटा रिसर्चको हेरेर मैले एउटा स्लाइडमा राख्न कोसिस गरेको छु, अझै यो भन्दा पनि धेरै छन्. बट व्हाट आई जस्ट वान्ट टु रिलेट, अब अहिलेको कुरा गर्दाखेरि चाहिँ सो रिस्क बिहेभियर्स यसले घटाउँछ भनेको छ. व्हेन वी अडप्ट द हेल्थ प्रमोटिङ स्कुल मोडल इन आवर कम्युनिटी, इन आवर स्कुल्स, त्यसले गर्दाखेरि चाहिँ आएको आउटकम चाहिँ यो रिस्क बिहेभियर्स कम पनि भयो. विशेष गरी स्मोकिङ, पोर डाइट रिड्युसका कुराहरू छ. त्यसै गरी मानसिक स्वास्थ्यमा पनि राम्रो चाहिँ यसले चाहिँ प्रभाव देखिन्छ, जसमा चाहिँ विद्यार्थीको वेलबिङ ओभरअल यसले इम्प्रुभ गरेको पनि हामीले पाएका छौँ भने अघि पनि भर्खर कुरा गऱ्यौँ, फिजिकल एक्टिभिटीको कुरा गऱ्यौँ. इट्स सो द्याट नो एनी काइन्ड अफ लाइक चेन्ज भएन भन्यो. तर आई थिङ्क यसले चाहिँ यो हेल्थ प्रमोटिङ मोडलले फिजिकल एक्टिभिटीलाई पनि बढाउँछ, मोर स्टुडेन्ट पार्टिसिपेसन हुन्छ भन्ने कुराहरूलाई पनि बनाएको छ. सो दिस आर all the global research findings that links with the healthy environments and also with the learning outcomes पनि. हामीले यहाँ हेल्थ मात्रै नभएर चाहिँ एट द एन्ड चाहिँ उहाँहरूको चाहिँ लर्निङ आउटकम्सलाई पनि राम्रो बनाउने चाहिँ यसको उद्देश्य चाहिँ रहेको छ. सो फलोइङ this is also one of the research that has been done. यो मैले इन्टरनेसनल रिसर्च देखाएको छु, सेम कुराहरू नै छ. त्यसमा चाहिँ नाउ हु विल बी द इम्प्लिमेन्टर भन्दा एउटा मोडल छ, जसमा चाहिँ विशेष गरी चाहिँ विद्यालय नर्सलाई चाहिँ यसको इम्प्लिमेन्टरको रूपमा चाहिँ ग्लोबली पनि यसमा राखिएको छ, WHO एन्ड अल द इन्टरनेसनल स्टडिज. र एभिडेन्सले पनि केही बताएको छ त भन्दाखेरि चाहिँ विद्यालय नर्सहरू मार्फत यो कार्यक्रम गर्दै गर्दा हेल्थ प्रमोटिङ स्कुलको मोडललाई एप्लाई गर्दै गर्दाखेरि चाहिँ एब्सेन्टिजम घट्या छ, त्यसै गरी स्टुडेन्ट एटेन्डेन्स इम्प्रुभ भएको छ, सँगसँगै उहाँको एकाडेमिक पर्फर्मेन्स पनि बढेको चाहिँ हामीसँग तथ्यहरू पनि रहेको छ. र यो नेपालमा गरिएको रिसर्च हो, जसमा चाहिँ यहाँले हामी देख्न सक्नुहुन्छ, जसमा प्राइभेट र पब्लिक दुइटै विद्यालयहरूमा गर्दै गर्दाखेरि चाहिँ के देखियो त भन्दाखेरि चाहिँ हामीलाई हेल्थ प्रमोटिङ स्कुलको मोडलको बारेमा त्यति धेरै थाहा नभए तापनि देयर इज सम कम्प्लायन्स विथ द स्ट्यान्डर्ड्स, र अझै हामीले काम गर्नुपर्छ. एन्ड बेसिकली चाहिँ के डिफ्रेन्स देखियो पब्लिक र प्राइभेटमा भन्दाखेरि चाहिँ पब्लिक स्कुल जुन हाम्रो सरकारी विद्यालय अथवा सामुदायिक विद्यालय अन्तर्गत चाहिँ मोर जुन अघि मैले हजुरलाई देखाएको थिएँ कोर कम्पोनेन्ट 5, 6, 7, 8 which is like operationalized in the school by the school, त्यहाँ चाहिँ मोर गभर्मेन्टको इन्टरभेन्सन भएर सो दोज कम्पोनेन्ट्समा चाहिँ एकदमै राम्रो खालको चाहिँ कम्पेरिटिभ टु पब्लिकमा चाहिँ दे हेभ द फ्यान्सी काइन्ड अफ इन्फ्रास्ट्रक्चर एन्ड अल द फिजिकल इन्भाइरोमेन्ट भने मोर फोकस टु द स्कुल हेल्थ सर्भिसेसको कुरा गर्दाखेरि चाहिँ पब्लिक स्कुलमा चाहिँ राम्रो भएको फाइन्डिङ्सहरू पनि छ. तर अझै पनि पिपल आर नट अवेर द्याट दिस इज द कन्सेप्ट, होइन, मोर चाहिँ हेल्थ प्रमोटिङ स्कुलको कन्सेप्टमा अवेर छैनन् भन्ने कुरा पनि यसले बताएको छ. एन्ड देन दिस इज अ क्विक लिस्ट अफ इम्पोर्टेन्स अफ HPS. मैले यहाँ हजुरलाई फेरि पनि राखेँ, लिटरेसी पढाउँछ, रिस्की बिहेभियर घटाउने कुराहरू पनि छ, लर्निङका कुरा, कोअर्डिनेटेड एप्रोच र यसले आत्मविश्वास पनि बढाउँछ भनेको छ। अनि सँगसँगै बुलिङका कुरालाई पनि जोडेका छौँ। अब नि अहिलेको यो दिज आर द एभिडेन्स द्याट आई सोड यु एन्ड देन देयर आर लट अफ एभिडेन्स अझै पनि छन्. बट नाउ फलोइङ द्याट एभिडेन्स वाट वी आर प्र्याक्टिसिङ राइट नाउ इज इन द फेडरल पोलिसी. वाट वी हेभ इज स्कुल हेल्थ एन्ड नर्सिङ सर्भिस गाइडलाइन इम्प्लिमेन्टेड फ्रम द फेडरल गभर्मेन्ट. अहिले प्रदेशमा पनि यो कामहरू भइ नै राखेको छ. प्रदेश सरकारले पनि यसलाई अपनत्व लिएर काम गरिराख्नु भएको छ भने धेरैवटा उद्देश्यमध्ये एउटा उद्देश्य भनेको चाहिँ वी वान्ट टु सर्टिफाई अल द स्कुल्स एज अ हेल्थ सर्टिफिकेट भनौँ हेल्थ प्रमोटिङ स्कुलको रूपमा सर्टिफाई गर्ने एउटा उद्देश्य पनि रहेको छ. बिकज वी हेभ द्याट एभिडेन्स द्याट इट हेज द्याट लर्निङ आउटकम पनि राम्रो बनाउँछ एन्ड देन एट द लाइक हुन्छ नि हेल्दी पनि बनाउने भयो. सो त्यो हिसाबमा चाहिँ हामीले एउटा उद्देश्य राखेको पनि छ. एन्ड वी आर डुइङ द्याट. वी हेभ अ स्ट्यान्डर्ड चेकलिस्ट बेस्ड अन द WHO ग्लोबल स्ट्यान्डर्ड्स द्याट वी जस्ट डिस्कस अबाउट. अनि हामी त्यही प्रयोग गरेर यसलाई सर्टिफाई गरी पनि राखेका छौँ. सो दिस इज जस्ट अ ग्लिम्स वाट द नम्बर अफ स्कुल हेल्थ नर्सेस इन द नेपाल गभर्मेन्टमा हामी 1407 इज लगभग 20% द टोटल सेकेन्डरी लेभल अफ स्कुल्स. एन्ड वी आर प्लानिङ टु एक्सटेन्ड मोर इन कमिङ फ्युचर. अब यो प्र्याक्टिसमा हामीले अघि पनि यहाँहरूलाई मैले भने जस्तै हामीले चाहिँ चेकलिस्ट छ. वी हेभ अ गाइडलाइन एन्ड देन देयर इज अ चेकलिस्ट. त्यो चेकलिस्टको आधारमा चाहिँ हामीले विद्यालयमा गरेर यो जुन अघि 1407 लगभग 1500 हाराहारीको विद्यालयमा हामीले त्यहाँ गएर मूल्याङ्कन गरेर हेल्थ प्रमोटिङ स्कुल छ भने सर्टिफाई गर्छौँ. एन्ड देन यदि छैन भने उहाँहरूलाई त्यो मोडलमा लानका लागि के ग्याप छ भन्ने कुराहरूमा मोर इङ्गेज पनि गराउँछौँ. एन्ड देन द इम्प्लिमेन्टर डेफिनेटली आर स्कुल हेल्थ नर्सेस. स्कुल हेल्थ नर्स नभएको ठाउँमा पनि हामीले गर्न सकिन्छ डेफिनेटली पनि. त्यो एडभोकेसी पनि हामी गरिरहेछौँ भने. बट अहिलेको समयमा फेडरल गभर्मेन्ट लगायत प्रोभिन्सियल गभर्मेन्टबाट डिप्लोय भएका सम्पूर्ण विद्यालय नर्सहरूले यो हेल्थ प्रमोटिङ स्कुलको मोडललाई चाहिँ अपरेसनलाइज गरिराख्नु भएको चाहिँ छ. So these are all of the health promotional activities that has been like यो हामीले गरि नै राखेको छौँ. फेरि अब यो एकदमै नयाँ कन्सेप्ट पनि होइन. इट हेज समथिङ इज बिङ डन अनि भइ नै राखेको छ. मात्र इन्टिग्रेट गरेर यसलाई हामीले हेल्थ प्रमोटिङ स्कुल भनेर यसलाई नामाकरण गरेका छौँ. यो यहाँहरूलाई जानकारी पनि छ. हामीसँग यो विद्यालय स्वास्थ्य र पोषण कार्यक्रममा विभिन्न कार्यक्रमहरू छन्. दिवा खाजा छ, डिवर्मिङ छ, आइरन फोलिक एसिड छन्, वास इनिसिएटिभ, स्कुल हेल्थ सर्भिसेस, हाम्रो रुटिन र क्याम्पेन भ्याक्सिनेसन, हेल्थ सबै भइरहेको छ. अघि भने हामीले डिस्कस गरे जस्तै ओरल हेल्थका कुरा भयो, INT एभ्री स्क्रिनिङ चाहिँ गरिरहेका नै छौँ. त्यो सँगसँगै यी सबै कुराहरू पनि हामीले हेल्थ प्रमोसन एक्टिभिटी के भइरहेछ त भन्ने हिसाबमा यो कामहरू पनि हामीले गरिरहेका छौँ. अहिले हामीले एडिसनल गरेको भनेको चाहिँ हेल्थ एम्बेसडर प्रोग्राम भनेर युथको लिडरसिप, एडोलेसनको इन्गेजमेन्ट र उहाँहरू मार्फत नै यो कार्यक्रमलाई चाहिँ अगाडि बढाउने हिसाबमा चाहिँ यो स्वास्थ्य राजदूत भनौँ अथवा हेल्थ एम्बेसडर प्रोग्रामलाई चाहिँ अगाडि पनि ल्याएको छौँ. सँगसँगै MHA पनि छ. भनेपछि यो लिस्टमा अझै पनि छुट्यायो होला, तर हामीले विद्यालयमा हेल्थ प्रमोटिङ एक्टिभिटी गरि नै राखेको छौँ. मात्र यो हेल्थ प्रमोटिङ स्कुलको स्ट्यान्डर्ड यो मोडलले चाहिँ यसलाई इन्टिग्रेट गरेर यसलाई इम्प्लिमेन्ट गर्नलाई चाहिँ हामी काम गरिरहेछौँ भन्ने पनि यहाँलाई मैले जानकारी पनि गराएँ. त्यो सँगसँगै वी हेभ द च्यालेन्जेस डेफिनेटली. एज वी नो द मेजर वान इज द रिसर्च, द मनी एन्ड देन अल द इन्फ्रास्ट्रक्चर्स एन्ड द हेल्थ सर्भिसेस एन्ड सम वेयर वी हेभ द पोलिसी ग्याप एज वेल. बिकज फ्रेगमेन्टेड हिसाबमा पनि कति ठाउँ काम गरिरहेका छौँ. बट यट हामी त्यसमा ओभरकम गर्न खोजिरहेछौँ. बट स्टिल वर्क्स हेभ बिन लाइक डन इन द फ्रेगमेन्टेसन एज वेल. एन्ड देन द इक्विटी इस्युज अल्सो आर देयर. अघि भने जस्तै अब पब्लिक स्कुलको फाइन्डिङ्सले दुईवटा कुराहरू बताएको छ भने सँगसँगै अझै पनि दूरदराजमाका विद्यालयहरूमा जाँदै गर्दा त्यो अझै पनि हामीलाई ग्याप्सहरू हामी देख्छौँ रिगार्डिङ द इक्विटिज. अब सस्टेनेबिलिटीको कुराहरू पनि हामीलाई लङ टर्म चाहिँ गभर्मेन्टको सपोर्ट डेफिनेटली पनि आवश्यक पर्छ जस्तो लाग्छ. सो दिज आर द च्यालेन्जेस. एन्ड द विद्यालय नर्सको यो जिम्मेवारीहरू मैले फेरि पनि क्विकली भन्यो भने कि टेक अवेजहरू चाहिँ आई थिङ्क विद्यालय एउटा त्यस्तो ठाउँ हो जहाँ हामीले दुइटै खालको अपर्च्युनिटी छ. एउटा हामीले लर्निङ आउटकमलाई बेटर बनाउने र स्वास्थ्यमा पनि हामीले काम गऱ्यौँ भने भोलिको दिनमा NCD लगायत अन्य जुन हामीले यहाँ छलफल गरिरहेछौँ त्यो विषयवस्तुहरू हामीले लाग्न सक्छौँ होला. HPSलाई हामीले मोडललाई चाहिँ अगाडि लान सक्छौँ भन्ने कुरालाई पनि राख्दै these are my references.
Thank you very much. Very valuable presentation. I now invite Dr. Harikrishna Baskota, invited speaker, Equities and Child Health and Nutrition Insight from NMICS 2024-25 research. Dr. Baskota is the chairman of Sahat Foundation. He is a medical professional with expertise in pediatrics and international health, and has been actively involved in healthcare leadership and community initiative. Over to you, Dr. Baskota.
मैले त देख्न पो गाह्रो रहेछ. सरी, चस्मा लाउँ. And mic, sorry. Thank you, Professor Madhusudan. Thank you very much for inviting me, and thank to NHRC for inviting me for this conference as a guest speaker. The, my first disclaimer is that it's not my data and all this. I'm using just mixed data. Mix is done around in 125 countries around every 5 years, and Nepal is one of that. And I'm trying to use the latest data of mix, which was released in 2020, this year, February, 2026, right? February. So this is my brief background. I retired from UNICEF, working in Nepal and others, and I have started a non-profit making organization to help the marginalized community. So I'll more speaking on behalf of the marginalized community. This is the summary of outline of my presentation for Nepal multiple indicator cluster survey, and how to prioritize reaching the poorest quintile, and what is the conclusion, what's called to my actions. So actually, as today morning, today afternoon, Saratji already on marks. One day we talk about the national average. It will not address what we will reach. So I'm also trying to unmax. He used the NDHS data. I'm using the Nepal multiple cluster survey data, and we move beyond national averages and to see disparities between provinces, wealth quintile, and the residences as well as. And we want to focus on the equity centered child health priorities and strategies. And I like to also call for action for reducing the vulnerable and reaching the vulnerable and most children with proven health and health and nutrition interventions. This is what I'm taking from this. I acknowledge for the UNICEF as well as the government for the mixed data. And this is the sample size. I'm not going in detail because I have very limited time. This is I did the secondary analysis of this using the data from discrete by 7 provinces, 5 with quintiles, and the mortality, nutrition, and indicators and immunization indicators. We see in the 25 years, Nepal has progressed a lot on under 5 mortality. We are in 31 latest, and we are in infant mortality 27, and 17 is the neonatal mortality. As we have done a progress, but still we are a long way from the SDG target because our SDG target is 25 for under 5, and the neonatal is around 12. So, and if you could see, the geographic determines survival. If you see, Bagmati and Gandakis are doing quite well. If these 2 provinces push little bit on newborn, they will reach the SDG target. But Sudur Paschim is 2.5 times higher. You could see then really we are around 2010 data of our mix in for Sudur Paschim. We really need to do work something differently in the geographical way in Sudur Paschim. And critical determinants, again, 55% of under 5 deaths occur during the first 28 days of life. Birth asphyxia, sepsis, and prematurity. These are the, if we can address this, we may prevent a lot of under 5 deaths. And another blind spot in our data is that if we go in the quintile wise, in the poorest is 3 times higher than the richest one, but the second quintile, the poor one, who is a policy blind spot, because these are the migrant people, day laborer, working in the informal sectors. They earn little bit, but the delay in the health seeking and others, their mortality child is around 45. So, which is significantly higher, around 3.5 times than the richest one for them. And we must celebrate our immunization coverage. We are actually basic antigen, I am talking, up by 9 months. This is 89% national level, but still we have long way to go to Karnali. And Gaddaki is doing well. So we really need to focus on Karnali, and Sudur Paschim is also doing well in immunization, but only in the mortality. But if we see the vaccination with wealth quintile, again the same second one, they are missing, because they are all informal peoples, informal doing things. They are even sometimes not in the record of the government systems and all these things. So we have to really, Dr. Radhika, you are here from the ministry, we have to really look on the second quintile. That is a policy blind spot which we really need to target. We have done steady progress on nutrition also, especially on stunting, underweight, and wasting also. But if we, now our stunting stands 26. But if we go on the unequal geographical, again, Karnali, highest stunting, and second, our food basket, Tarai, Madhya Pradesh. If we see the wealth quintile wise, the highest stunting is in the poorest children, 40, then the richest, because the food, there is a child food poverty, which we shall say the child food poverty. And again, my friend was little bit, see here, 63% of the children in Madhya Pradesh don't have a sufficient diversified food. Child food poverty, if we have to have at least more than 5 diversified quality food. If we have below 5 to 2 to 4, then we call it moderate child poverty, food poverty. And then if we 0 to 2, then we call severe. Where are we in Madhya? See, in the Madhya, because especially the children in Madhya, actually I didn't show that data here, around 30% children take only 2 times food. This is the challenge, and really a behavioral issue comes here. Is not availability of the food, but is the junk food, like one of my friend calls patru food, you know, we all know that. The junk food and all these things, the children are pacifying, but they are not taking the good quality food. So poorest children face higher rates of food poverty than the richest one, we could see. That's and there is a huge relation between the malnutrition and the mortality. If we don't tackle, 45% malnutrition are associated with mortality. So we have to work on the malnutrition, especially again another comes the micronutrient deficiency, which we call hidden hunger. Around 50% of our under 5 children suffer from anemia, and 1/3, 33% of mothers suffer from anemia, pregnant mother. So women of reproductive age. So this, and even the adolescent girls. And what are the key? What are the key intervention we may have to think? These are my some suggestion. So we have to poorest 36 under 5 mortality. Second cool 45. Even we and stunting 40%. Key intervention we have to do. Don't go for blanket. Our resources are limited. We do the conditional cash transfer linking to ANC, PNC, MNH, and immunization. Really, we should not go for a grant with though I am a pediatrician, but I am saying don't go. It's not feasible. It's not possible. It's not long term. But target who needs really. Though then we can make a difference. And there is subsidized nutrition, food supplementation, quality, and the output therapeutic feeding, micronutrient, and supplementation. Maternal. Even there is a Balvita is available, but they are not using. They are dumped in the health post, and these are really a challenge. We have to really look on those things also. Logistically, there are a lot of logistic things are there, but they are not used. I have seen that in different facilities during some of my assessment. And integrated health and nutrition support, community health support, school nurse support, community health nurse support. You guys are coming with new community health nurse. This is critically important to reach the last mile, and home visits and referral system and quality MNCH, and 0 dose and missing children is also critically important. Around 1.7% children are still 0 dose, no vaccine at all. That is around 7,000, and missing children are 11%. That is 44,000. And WAS has a big role to play. And then lastly, the social protection, child with grant health insurance is important, and addressing the policy blind spot for second quintile, and children with special need, that's also need to be addressed. So in my conclusion, national progress hides the inequity. We must unmask it and look on all the indicators, looking on the geography, wealth quintile, and everything, and where the child is born determine the survival. As I mentioned, Gandaki and the Sudur Pasim is quite different. Poverty remains a key determinant for survival of our children, and there is a policy blind spot. Especially, I like to highlight the second quintile now. And then coverage equity. Expanding service alone is not enough. Who benefits matters is much, and how many are reached. That's also important. And call to action. This is my last slide. So I really want to equity-centered child health agenda is critically important. We have to shift the goal, move beyond coverage to deliver equitable integrated health and nutrition care for every child, and target the most vulnerable, prioritize high burden provinces and poorest and marginalized children where the need is greatest, address the hidden gap, and recognize the second health quintile, and scale what works. Don't go everything. Invest in perinatal health. That makes a big sense in the neonatal mortality and the maternal mortality reduction also. We are 151 for the 100,000 maternal mortality still. So perinatal care is critically important. Nutrition, immunization, wash and strong referral system, and act together with urgency. Align federal provinces and the local policies to strategically drive evidence-based equity focused multi-sectoral health and nutrition intervention for meeting the SDG targets. This is my acknowledgement. This is a dome community which I have doing some research on them. This is so they really looking forward for us, and thank you. And today morning actually some of these slides I presented to the Nepal Pediatric Society. Around 225 pediatricians were there. 25% of pediatricians. I challenged them also as a senior pediatrician. Similarly, I'm not challenging here. I'm requesting the Ministry of Health and the government to look on this. And I really I look really forward that the government, new government with new policy, new Bacha Patra, and all what not new will come with some of the good innovations to reach those children with the last mile. Thank you very much.
Thank you, Dr. Baskota, for providing us with the recent data to guide nutrition policy. And now I invite Sarah E. Bauman to present on exploring key influences of menstrual seclusion in Nepal nursing social networks analysis. She is a PhD, assistant professor, filmmaker, and scholar of participatory and creative research method. The floor is yours.
Thank you. I'm the last presentation, right? So we will stay awake for just 10 more minutes. I don't know if this is working. Do I push this? Okay, sure. We need to stretch and wake up a little bit. Just 10 more minutes. Yes, thank you. Okay. So thank you all. I am going to be presenting on behalf of our team who is doing a social network analysis of key influencers around menstrual seclusion in Nepal. So we have a 5-year study. Actually, that's a co-design, human-centered design study, and this is a sub-study beneath that because we realize that we really need to have better data on targeting and understanding who are the key influencers of this tradition so that we can effectively intervene. So as you all already know, menstrual seclusion is a religiously and socially situated practice and very complex in Nepal. We have women and girls following a range of restrictions every month, from restrictions in everyday activities to residing in separate spaces for sleeping for the duration of their menstrual cycle, and sometimes post-childbirth as well. Despite the significant health risks posed by menstrual seclusion, there is little known about how to influence these behaviors and promoting health and safety during menstruation. So chaupadi is a term that many of you, probably all of you, have heard. So all participants in our study identified as practicing chaupadi. But what does that mean? We don't have a standardized definition of chaupadi in Nepal. So we adopt this term in this presentation because this is the term that our community that we worked with used, recognizing that this definition may vary across different villages and even within this village, right? So in our study, interestingly, the behavioral restrictions that they identified as being associated with the chaupadi practice were 100% of them said that they had no involvement in religious activities during menstruation, and 100% of them said they avoid the kitchen. This was clear across all our participants. However, you can see that while all of them followed different sleeping arrangements during menstruation, some of them sleep outside the home, some of them sleep in a separate place inside the home. They all defined that as still practicing chaupadi, sleeping in a separate space, which is quite interesting actually. So given the social pressures in communities to follow menstrual restrictions each month, we aimed to reveal who are some of these key influencers behind menstrual restrictions? And what are the relationships that they have with these individuals? How might we learn more about these relationships so that we might be able to shift towards healthier practices? That was really our goal. We are hoping to use this information to inform this co-design intervention development that we're doing over the next couple of years. So just a little bit about social network analysis, the method that we used. So this is a set of methods for the analysis of social structures, particularly the relationships within a structure. It grew out of the fields of sociology, psychology, and organizational studies. And the central idea here is that the relationships that we have with each other matter. These matter in terms of decision making, but also in adopting different behaviors. So relationships are truly at the center, so we have to understand the nature of these relationships. The data for this study is primarily quantitative, but we also collected qualitative data. Unfortunately, I can't share the qualitative data today, but what we're hoping to do is use that qualitative open-ended outcomes to kind of triangulate and understand these complexities within the quantitative data. Throughout the presentation, you'll hear me use the terms ego and alter. So ego is the person being interviewed. That's the woman who practices chaupadi. Alter is the person that we're asking about the relationship with. So those are the people that the woman has a relationship with who are influencing their chaupadi practices in some way. So this image here on the right is an example map of a social network analysis where the person we interview is the white dot in the middle, and there's these other relationships surrounding them with different characteristics that we can study to understand how they influence behaviors of that ego in the center. So just quickly about our methods. So this data was collected from Dailek, Nepal, where there is a high prevalence of chaupadi. And for sampling, we had a research assistant work with the female community health worker in 2 villages, developing a local community map to identify all of the households. And then she developed a skip pattern based on our ideal sample size. And so she went house to house, approaching in each house, and if she found a woman who practiced chaupadi there, she interviewed the first woman who practices chaupadi in that selected household. So in total, we had 46 women from 2 separate villages, which is consistent sample size with an exploratory data set for a social network analysis. And for each participant, we essentially asked them, who influences your practices around chaupadi? Who are the important people we need to know about? And they were able to nominate up to 5. Some of them nominated 1 person, some of them nominated 5, so there was a range of people that they could nominate. So we collected the quantitative data verbally through an administered survey, through a research assistant. There were 59 questions in total. If they nominated 5 people, we had to ask about demographics and relationship characteristics from all of those folks. So it took about 40 minutes to complete that survey. And we also collected relationship characteristics. How long have you known this person? How often do you have contact with this person? Because in social network analysis, we believe that those might be important factors to consider in those relationships. And then interestingly, we also asked a question about whether this person, this relationship, could actually influence them to change their practice. So it's one thing to influence them to practice it, but it's another thing to have the power to change it. So we also asked about that. So I'll share some of those preliminary findings. We are still ongoing with the analysis, so I'll give you that caveat. We still have some of the analysis to go, but this is just a snapshot. So here's a look at our data set. We had 46 egos, 46 women who practiced chaupadi, where we asked about their relationships. Their mean age was 27, from a range of caste backgrounds. They were all Hindu. Most were employed and married. And interestingly, all of them expressed that religion was either very important or important. So quite high in terms of religiosity. And then when we asked about their relationships, we were able to gather data on the relationships of women with 218 different people. Most of the women nominated 4.7 alters. That was on average. So what this tells us is that there's not one person influencing their practice. There's actually many people in their sphere of influence who are influencing their practice. And you can see a little bit about the demographics of those participants here. But this is the main thing that I wanted you all to see. So this is the social network map that comes out of the social network analysis. And what stands out to me is a lot of blue. and blue are the family members. So the question here is, who influences your decision to practice Chaupati or menstrual seclusion practices? And you can see a lot of blue. Many family members are affiliated with this influence. But we also see friends and neighbors, some of the purple and pink, and we see some of these red dots as well. Those are the faith healers, the Dami Jakris, which you probably expected. They are influencing their practice in some way. No teachers. Now we asked, who can actually influence you to stop practicing Chaupati? If you no longer wanted to practice it, how could we stop that, right? We're trying to get a sense of who has the power here. And so this is a little bit hard to see, but you can see the rectangles are maybe. They might be able to change my ability to practice Chaupati. So what we see here is family members are still there. Family members, some of them thought maybe they might be able to change. But among the friends, and especially the friends, you see almost all of the pink are rectangles, not circles. So that tells us that the friends are really, of all the friends nominated, the friends potentially have the power to shift these practices. So that's quite interesting. I'll say a little bit more about that in my conclusion. So the other thing that we looked at was relationship length. What does it matter how long you know people? Does it matter if you interact with this person often? And we find that it does. Most of the contact with the influencers was once a week, and people that they've known for more than 10 years. So having someone come in quickly to change their practices, some expert from the outside, is maybe not how the practices are going to shift. This is what our initial analysis we're thinking through. So what does all this mean? In our initial analysis, I say it's still ongoing because we want to bring the qualitative in as well to try to gather a little bit more nuance here. But what we're seeing from the quantitative data is that family members are the most common influencers of Chaupati. They are not necessarily most poised to change menstrual seclusion practices. So only a few mentioned that their family members could convince them to change. So they're influencing them, but I don't think they have the power to change me, right? The religious leaders, like faith healers, were also influential in the practice, but they were not identified as people who could or would change the practices. So also important. So what we're seeing here is that these loose tie relationships, like friends or neighbors who still contribute to the social norms in the community, may be positioned to leverage change in some unique way. So I think there's something special here happening with friends and neighbors that we need to look into a bit more. And then also people that are in common contact and have long-term relationships, those long-term neighbors and friends could be powerful. So here's my takeaway implications, and I will stop there and thank my team. Thank you so much.
Thank you, Sarah. So thank you all. Let's, if you have a very precise question to the particular presenter, we can take 1 or 2 questions. Yes, please.
Talked about during the presentation session. So my question is one question to Rajan and Sulataji, that because you were closely involved in the community engagement, are you here? Okay, yeah. So, okay, yeah, sorry.
Yeah.
So I was just thinking, like, if you identified any people in the community, because you also promoted the community health volunteers, right, in the session. So were there any other people, other than the people involved in the health sector, that you think could be involved in the health programs, for example, any in cities?
Thank you. Yes. Let us take 2 more questions, and then, because in the interest of time, and today we don't have dinner.
So myself began
Yeah.
Subedi. So
Yeah.
my question goes to the last
Yeah.
presentation. So you have identified that the family are the influencing, but not have the power to change. I have a curiosity, like people already feeling hopeless, that the family have the power, they have influence, but because they are already feeling hopeless that they cannot change. This might be influencing factors, because they might feel that friends will tell their family, and actually that will change. So they do not believe to the family but to the friends.
Is
So
it your
this might
question or remarks?
Yeah, my curiosity and question.
Okay.
So this might have change the data? Have you explored about this?
Okay, let us finish the 2 questions. Rajanji, Sulataji.
हजुर नमस्कार, म डाक्टर राम थापा छेत्री, हाल स्वास्थ्य बिमा बोर्डमा कार्यरत छु। मेरो गृह जिल्ला धादिङ। मेरो प्रश्न चाहिँ हाम्रो डाक्टर बास्कोटा सर मार्फत छ। एकदमै सरको सान्दर्भिक प्रेजेन्टेसन छ। म पनि बालबालिका बचाउँ भन्ने एउटा अभियान लिएर हिँडेको छु र यही क्रममा मैले धादिङ, मकवानपुर, चितवन, गोर्खा, लमजुङ र जाजरकोटका करिब 1 लाख बालबालिकाहरूलाई कम्प्रिहेन्सिभ स्कुल हेल्थ प्रोग्राम भनेर सञ्चालन गरेँ र मैले अधिकांश सरकारी विद्यालयहरूमा के पाएँ भन्दाखेरि
क्वेशन सोधौँ।
हजुर क्वेशन आउँदैछ क्वेशन
क्वेशन सोधौँ।
यसमा चाहिँ हाम्रो देशको समस्या गरिबी र सबै खालका चाहिँ संक्रामक रोगदेखि लिएर बालबालिकाको समस्या चाहिँ सरकारी विद्यालयमा देखिन्छ। उनीहरू न्युट्रिसनबाट पनि अभावमा छन्, उनीहरू रेबिज रोग लाएर मरिरहेका छन्। ती बच्चाहरू चाहिँ सरसफाइ कमीले गर्दा संक्रामक रोगबाट ग्रसित छन्। दिवा खाजामा पनि भेदभाव छ, सफा खानेपानी छैन, स्कुल ड्रेस छैन, लगायत चिसुका कुराहरू धेरै छन् र भिरबाट लडेर घटनाहरू पनि बढिरहेछन्। र यसमा चाहिँ अझ चेपाङ समुदायको अवस्था त्यो गम्भीर छ। यसमा नेपाल सरकारले स्वास्थ्य मन्त्रालयले चाहिँ अबको हाम्रो स्वास्थ्यको चाहिँ हाम्रो कार्यक्रमहरू चाहिँ विद्यालय केन्द्रित किन नगर्ने, हाम्रो स्कुल हेल्थ नर्स मार्फत हामीले समाधान गर्न सक्ने कुराहरू किन नगर्ने र स्कुल हेल्थ प्रोग्राम मार्फत र सबै सूचनाहरू हाम्रो जुन सूचना केन्द्र छ मन्त्रालयको शाखामा त्यो त्यहाँ हामीले फेसबुकमा पोस्ट गर्नुभन्दा ती विद्यालयका भित्तारमा किन नटास्ने र सरले चाहिँ यसलाई
तपाईँ क्वेसन बुझ्यो, तपाईँ क्वेसन बुझ्यो, एकदम राम्रो, धन्यवाद। ल यो 3टा क्वेसन सकौँ अनि ताराजीलाई एउटा लास्ट। ल एन्सरले एकदम 30 सेकेन्डमा सकाउने गरी गर्नु होला। अरू बाँकी इमेल ल्याउनु होला साथीहरूसँग है।
ल धन्यवाद। कम्युनिटी इन्गेजमेन्टको क्वेसन गर्नुभएको थियो। अब कम्युनिटी इन्गेजमेन्टमा हाम्रो इन्टरभेन्सन चाहिँ अब पिपलको लागि भएको भएर, कम्युनिटी पिपलको लागि भएको भएर उहाँहरूकै डाइरेक्ट इन्गेजमेन्ट फर्स्टमा चाहियो। किनभने हामीले उहाँहरूको लागि काम गर्दैछौँ, उहाँहरूको प्रेफरेन्स के छ, उहाँलाई के चाहिएको छ, उहाँहरूले हामीले भनेको कुरा बुझ्नुहुन्छ कि बुझ्नुहुन्न। हामीले हाइपरटेन्सन भनौँला, ब्लड प्रेसर भनौँला, उहाँहरूले प्रेसर भन्ने कुरा बढी बुझ्नुहुन्छ, सुगर भन्ने कुरा बढी बुझ्नुहुन्छ। हालाकि सुगर भनेको नट अ गुड टर्म, तर सुगर बढी बुझ्नुहुन्छ उहाँले मधुमेह भन्दा। त्यस कारणले अब कुन चाहिँ मेथड उहाँहरूको प्रेफरेन्समा पर्छ, कुन चाहिँ वर्ड्सहरू कुन किसिमले कोबाट आयो भने, त्यस कारणले देमसेल्फ जसको लागि हामीले चाहिँ नि इन्टरभेन्सन बनाउँदैछौँ उहाँहरू आफ्नै चाहिँ इन्गेजमेन्ट चाहिँ एकदमै ठुलो हुन्छ। त्यही भएर को डिजाइनिङमा हामीले
थ्याङ्क यू। सुलताजी हुनुहुन्छ? ल प्लिज।
एडिङ टु राजन्स एन्सर, यसमा चाहिँ अब हामीले चाहिँ एनसिडीको इन्टरभेन्सन भएको भएर चाहिँ हामीले लोकल कम्युनिटी ग्रुप्स, सो स्पेसिफिकली हामीले टार्गेट ग्रुप्सहरू चाहिँ युथ, वुमेन्स ग्रुप र मिक्स एडल्ट ग्रुप राख्नुको एउटा रिजन्स भनेको चाहिँ हाम्रो सबै डाइभर्सिटी र कम्युनिटीको रिप्रेजेन्टेटिभ होस् भनेर हो। सो एक्सेप्ट कम्युनिटी हेल्थ भलिन्टियर्स, सो who are already overwhelmed with lots of community works, so we can also thought of lay community members. For example, we did that process following the consultation with local gatekeepers or stakeholders. Ani community ma चाहिँ number of existing networks पनि छ. For example, local clubs haru छ हैन, school volunteers haru छ, plus women's group र cooperative groups haru पनि छ. त्यो existing groups को members लाई चाहिँ as a volunteer पनि चाहिँ हामीले mobilize गर्न सकिन्छ.
Thank you. Sarah.
Thank you so much for the comment and your analysis. I really appreciate that, and I will say that the limitation of this data is that it's only the quantitative insights, right? It will tell us who is the influencer and who has the power, but it won't tell us why. But you're getting at this, why is so important. And so we did have one open-ended qualitative question. If they told us that that person has the power to change, we did ask them why. Unfortunately, that's still being analyzed. We have the qualitative data being coded right now. So if you want, we can be in touch, but I would love to continue this conversation because for us as well, I think it demonstrates the power of mixed methods. I think a social network analysis alone, even with a huge sample size, is very interesting, but without that qualitative insight that gets at those complexities, I think it's going to be a huge limitation. So I'm excited to share the next phase soon.
Thank you. Let me speak in English so Sarah also understand. Thank you very much. Sorry, I Nepali. Okay, then fine. तपाईले जुन भन्नुभयो really appreciated हैन. The school could be a very good entry point. र तपाईँको अघि हाम्रो मल्टी सेक्टर न्युट्रिसन प्लानको चाहिँ कतै कुरा भएको थियो यहाँ भएको भयो जस्तो लाग्यो उतापट्टिको त त्यसमा चाहिँ के अरे 7 मिनिस्ट्रिजहरू प्लानिङ कमिसनको अन्डरमा आएर यो न्युट्रिसन र तपाईँले जुन पोभर्टीको यो कुरा सोसियल डिटर्मिनेन्ट्स अफ हेल्थ भन्छ त्यसको चाहिँ एड्रेस गरिरहेको छ। मैले बालाजीलाई भने पनि अघि बालाजीले एकदम राम्रो पोइन्ट ल्याउनु भएको छ। के भन्दाखेरि अहिले चाहिँ लुम्बिनीले एउटा रोबिङ नर्स भन्ने सुरु गरेको छ रिसेन्टली। त्यसमा पनि स्कुल हेल्थ प्रोग्राम चाहिँ उहाँहरूले चाहिँ कम्युनिटी प्लस स्कुल दुइटैमा काम गर्नु छ उहाँहरूले रोबिङ नर्स। त्यो एउटा अर्को चाहिँ इन प्लस उहाँले भन्नु 1400 जति गभर्मेन्टको अहिले 1800 त अलिक घटिसकेर 1400 जति स्कुल नर्सहरू हुनुहुन्छ। उहाँहरूलाई अझ ट्रेनिङ उहाँहरूलाई अझ गर्ने भने स्कुल द चिल्ड्रेन्स आर द भेरी गुड चेन्जर। मैले त उज्बेकिस्तानमा काम गर्दा मैले आयोडाइज सल्टको विषयमा हेर्दाखेरि चिल्ड्रेनले ठुलो चेन्ज ल्याएको मैले देखाएको छु। त्यस कारण द्याट्स अ भेरी गुड पोइन्ट होइन। अर्को तपाईँले भन्नुभयो जुन मार्जिनलाइज समुदाय त तपाईँले त चेपाङ समुदाय देख्नु भएको छ। एकचोटि तराईतिर जानुहोस् न, बारा पर्सा रौतहट सुनसरी है ठिक छ त्यो जानुहोस् अनि हेर्नुहोस्। त्यहाँ अझ फुड पोभर्टीको कुरा गरेँ नि मैले, चाइल्ड फुड पोभर्टीको चेपाङमा त हाम्रो धेरै प्रोग्राम पुगिसकेको छ। वी ड्यु रेस्पेक्ट
डाक्टर थापाले हाम्रो डाक्टर साहबको इमेल ल्याउनु पर्यो अनि डिटेलमा खोज्नु पर्यो है त। ग्रेट। ल फाइनल क्वेसन तारा।
हुन्छ सरलाई धन्यवाद। सबै प्रेजेन्टर्सहरूलाई चाहिँ एकदम एक्सिलेन्ट प्रेजेन्टेसनको लागि पनि धन्यवाद। मेरो क्वेसन चाहिँ इक्विटीमा प्रेजेन्ट गर्नुहुने सर द्वय, आज त अहिले त शरदवन्त सर हुनुहुन्न होला, डाक्टर बास्कोटालाई नै हो मेरो यो एउटा प्रश्न चाहिँ। दोस्रो चाहिँ हाम्रो सरलाई नै हो होइन। पहिलो चाहिँ के हो भने म ताराप्रसाद अर्याल हड इन्टरनेसनलमा काम गर्छु डेटा साइन्स डिपार्टमेन्टमा। हामीले पढेको इक्विटी भनेको चाहिँ इट इज अ मल्टिडाइमेन्सनल एन्ड इट वर्क्स अन्डर द प्रिन्सिपल अफ इन्टरसेक्सनालिटी भनेर पढेको थियौँ होइन। तर मलाई के लाग्छ भने हजुरको प्रेजेन्टेसन मैले पनि यो एनालिसिस गर्ने मौका पाएको थिएँ। हामीले चाहिँ एउटै डाइमेन्सनबाट चाहिँ डिसिजन लिँदाखेरि चाहिँ मिसलिडिङ हुन्छ कि भन्ने मेरो कन्सर्न। फर एक्जाम्पल वेल्थ क्विन्टालको आधारमा मात्रै डिसिजन लिने कि वेदर अ पुवर गर्ल हु इज फ्रम रुरल एरिया मेबी मोर डिसएडभान्टेज त्यो हुनसक्छ, अथवा विदिन ग्रुप तपाईँको हेर्नुहुन्छ भने पुवर क्विन्टाइलमा चाहिँ विदिन ग्रुपको भेरिएसन कस्तो छ त्यो पनि हेर्नु पर्ने हुनसक्छ होला। एउटा त्यो भयो मेरो प्रश्न हजुरलाई। हजुरको कन्क्लुजन देखेर मलाई चाहिँ
ल अब धेरै नसोधौँ तारा, एउटा छ पुग्यो। ल अब एन्सर गर्नु सरहरूले 30 सेकेन्ड। ल 30 सेकेन्ड। ताराको त सोधिसक्नु हो तपाईँले क्वेसन।
सोधेको छैन
हो
ओके हो थ्याङ्क यू। म यो डाटा एनालिस्ट साइन्टिस्ट त होइन म चाहिँ प्रोग्राम लिडर हो, प्रोग्राम सिस्टम हेर्ने हो है। अब त्यो डाटा एनालिस्ट त मेरो साथीहरूलाई ल्याउनु पर्ला। तर चाहिँ मैले चाहिँ बेसिकल्ली के देखाउन खोजेको भनेदेखि हामी फोकस्ड हुनु पर्यो। हामी यो एकाडेमिक एक्सर्साइज गरेर बसेर हामीले कहीँ पनि पुग्दैनौँ। जस्तो मैले फोकस कहाँ गरेँ भन्दाखेरि मैले पुवरेस्ट भन्दा पनि सेकेन्ड क्विन्टालमा फोकस गरेँ आज। मेरो मेसेज चाहिँ मन्त्रालयको हाम्रो म्याडम हुनुहुन्छ उहाँलाई मैले के भने म्याडम यो सेकेन्ड क्विन्टाललाई हेर्नु पर्यो। यो जुन अहिले मार्जिनलाइज पपुलेसन जो माइग्रेन्ट छन्, यहाँ लेबर छन्, काठमाडौँमै बसेका छन्, बागमतीको किनारमा बसेका छन् अथवा अरू विभिन्न ठाउँमा बसेका छन्, रेगुलरली आउने जाने छ, उनीहरूको चाहिँ नो रेसिडेन्स जस्तो तिनीहरूलाई हेर्नु पर्यो। तिनीहरूलाई चाहिँ हामीले भ्याक्सिन पुर्याउनु पर्यो, तिनीहरूलाई हेल्थ सर्भिस पुर्याउनु पर्यो। त्यो पछि कुरा हो, त्यो इन्फर्मल सेटलमेन्ट के छन्, तर हामीले लाइफ त बचाउनु पर्यो। मेरो भनाइ चाहिँ आजको उद्देश्य त्यो। तर तपाईँ र म यो एक्सर्साइज गर्ने सँगै बसेर गरौँ, तपाईँबाट म धेरै कुरा सिक्छु।
अब हामी अन्तिममा छौँ। विशेष त सम्पूर्ण प्रस्तुत गर्ने प्रस्तुताहरूलाई र अडियन्सलाई धन्यवाद दिन चाहन्छु। अबको हाम्रो बाटो भनेको आज जति पनि रिसर्चको फाइन्डिङहरू भयो त्यसलाई चाहिँ पोलिसीमा कहाँ लान सकिन्छ भन्ने कुरा नै हो होइन। जुन कुराहरू आएको छ अफकोर्स हामीले पोलिसी चेन्जहरू गर्नुपर्ने होला, स्ट्रक्चरल चेन्जहरू गर्नुपर्ने होला, सोसियल चेन्जहरू गर्नुपर्ने होला। एउटा मलाई साराको फाइन्डिङ, हामीले जहिले पनि टिचर्सहरूबाट चेन्ज ल्याउँछौँ भनिरहन्थ्यौँ, तर अहिले टिचर्स चाहिँ रहेनछ भन्दाखेरि अलिकति हाम्रो लागि नै सकिङ जस्तो रिजल्टहरू भयो। त्यस कारणले अवश्य पनि अबको दिनमा मन्त्रालय विशेष त हामीले अब यो वाइडर डिटर्मिनेन्ट्स अफ हेल्थमा हेर्दाखेरि चाहिँ कहाँनिर चाहिँ चेन्ज गर्नुपर्ने रहेछ भन्ने कुराहरू हामीले यसलाई एनालाइसिस गर्छौँ र सायद त्यो अनुसार मन्त्रालयले गर्छ पनि होला। अन्तमा यो अपर्च्युनिटी एनएचआरसीलाई आभार व्यक्त गर्दै म आफ्नो मन्तव्य यहीँ टुङ्गाएर सरलाई माइक हस्तान्तरण गर्छु।
थ्याङ्क यू। सबभन्दा पहिले त तपाईँहरू सबैलाई एकदम साँझसम्म बसेर सबै सुनिदिनु भयो। यो सुन्ने व्यक्तिहरूलाई धेरै धेरै धन्यवाद है। 100% अटेन्डेन्स प्रेजेन्टरहरूको उहाँहरूलाई त धन्यवाद हुँदै हुँदैन है। हाम्रो यो ज्ञानको यो नलेज प्रोडक्सन, नलेज डिसिमिनेसनको कुराहरू हो। एनएचआरसीको नेसनल सब्मिटमा सबै लेभलको हाम्रो प्रेजेन्टरहरू हुनुहुन्छ, इन्भाइटेड प्रेजेन्टरहरू हुन्छ, सिनियरहरू हुन्छ, एकदमै यङ इनर्जेटिक पिएचडी पोस्टडक फेलोजहरू हुनुहुन्छ। अनि यो सबै पोलिसी मेकरहरू, गभर्मेन्टमा सिस्टममा बसेको व्यक्तिहरू हुनुहुन्छ। उहाँले चाहिँ यो एभिडेन्सबाट के छ, त्यसमा के भइरहेछ र हामीले के गर्ने होला भन्ने हुटुटी भएको मान्छेहरूको लागि चाहिँ यो राम्रो प्लेटफर्म हो भन्ने लाग्छ। यो अर्थमा आजको सेसन एकदमै प्रोडक्टिभ हो। सबैभन्दा मैले धन्यवाद दिनुपर्ने चाहिँ सबै प्रेजेन्टरहरूले टाइममा सकाइदिएर यो समयमा सकिया हो, नत्र सकिन्थेन है। लास्टमा म के भन्छु भने यो ताराजीले अहिले उठाउनु भएको इस्युहरूलाई हुँदै हामीले यो इक्विटीको कुरा गर्दाखेरि अफकोर्स इन्टरसेक्सनल पर्सपेक्टिभ हेर्नु जरुरी छ होइन। जस्तो मधेसको कुरो आयो, कर्णालीको कुरो आयो, हामीले भनिरहने कुरो त्यही हो। मधेस मार्जिनल छ, डिसएडभान्टेज छ, सुगम भन्छौँ हामी, त्यो धेरै दुर्गम देखिन्छ डेटाहरूले, कर्णाली दुर्गम देखिन्छ भनेर भन्छ। तँलाई चाहिँ एउटा चाहिँ दुईवटा पाटोमा हेर्नुपर्छ जस्तो मलाई लाग्छ। एउटा चाहिँ नेसनल एभरेजले एउटा इन्डिकेटर गर्छ, यस्तो खालको कास्ट, इथनिसिटी, इन्कम, लोकेसनले अर्को इन्डिकेटर गर्छ। तर त्यसलाई मात्रै नहेरेर इन्टरसेक्सनल पर्सपेक्टिभमा हेऱ्यो भने हु आर द रियल मार्जिनलाइज, डिसएडभान्टेज, टु बी टार्गेटेड पिपुल भनेर एकदम क्लियर हामीले एउटा पिक्चर देखाउन सक्यौँ भने त्यो देखाउने कुरा चाहिँ रिसर्चरको कुरा हो। त्यो क्लियर पिक्चर देखाउन सकियो भने सायद पोलिसी लेभलमा बस्ने व्यक्तिहरूलाई हामी अहिले पनि भनिरहेछौँ एभिडेन्स इन्फर्म पोलिसी भन्छौँ। त्यो एभिडेन्स जेनेरेट गर्ने चाहिँ यही स्कलरली कम्युनिटीको कुराहरू हो। त्यो पोलिसीलाई चाहिँ बनाइसक्यो भने ल है, अब सबै कर्णालीमा सबै तराईमा भन्यो भने पोलिसी बन्दैन। त्यो भित्र पनि को त? त्यो भित्र पनि मधेसी दलित हो कि, अथवा मधेसी दलित भित्र पनि महिला हो कि, त्यसलाई चाहिँ क्लियरली स्पेसिफाई गर्न सक्यो भने हाम्रो पोलिसी फर्मुलेसनमा, इम्प्लिमेन्टेसनमा, मोनिटरिङमा, इभ्यालुएसनमा सजिलो हुन्छ होला र हाम्रो पोलिसीको म्यामहरू हुनुहुन्छ, सरहरू हुनुहुन्छ, एम चेयर नै हुनुहुन्छ, उहाँहरूलाई चाहिँ सजिलो हुन्छ होला भन्ने लाग्छ। अन्तमा यो भन्छन् नि सुन्नेलाई सुनको माला, भन्नेलाई फुलको माला, यो ज्ञान सबैतिर पुर्याउला। सबैलाई धेरै धेरै धन्यवाद भन्दै म सेसन क्लोज गर्छु। ओभर टु यु अर्गनाइजर।
Thank you, sir. Thank you to all our presenters for sharing your work so thoughtfully. Your presentation have added fresh perspective and helped us better explore key issues around health inequalities, social determinants of health, and health education and promotion. To recognize your contribution, I now invite our session chairs to present a token of appreciation. Chairs, please come on dais. As I call your name, please come forward to receive it. And I invite all the audience to join me in a round of applause as each presenter receive their token of appreciation. Invited speakers, Professor Dr. Sharad Raj Onta, Dr. Bipin Adhikari, okay, Ms. Bala Rai, Dr. Hari Krishna Baskota, Ms. Sarah E. Bowman, Ms. Kritika Dikshit, Ms. Sulata Karki, Mr. Rajan Shrestha, Miss Amy Gray Zasilo, Mr. Ratna Mishal, and Ms. Susmita Nyupani. A heartfelt thank you to each of you for the dedication and effort you have put into your research and presentation. Now I would like to kindly invite Dr. Hari Prasad Dhakal, Executive Board Member of NHRC, to come forward and present a token of appreciation to our session chairs. May I also request all the presenters to please join us on stage along with our respected chairs for a group photograph. This brings us to the end of parallel session 8. A warm thank you once again to our chairs, all the presenters, everyone in the audience for making this session meaningful. We look forward to welcome you tomorrow.